Okay.
Welcome everybody to the Health and Government Operations Committee. Though Vice Chair Penny Melnick will be chairing this meeting, I wanted to make a quick announcement at the beginning. We have a clarification in our rules. It's come to my notice that sometimes when we have favorable with amendment testimony, it may be treated differently. It may be added to a panel. It may be treated as its own panel. So I wanted to clarify this, and the rules will be posted on the website by the end of the day today. I'm just trying to get the rules as readable as possible. Working with my subcommittee chairs, what we've decided to do is call them three different categories because of course they are. Favorable is a straight favorable. Favorable with amendments varies anywhere from favorable with a little tweak to I really want to kill this bill, so I've got 3 pages or 12 pages of things to change to make it work for me. So it's neither favorable nor unfavorable. So we're going to give those 5 people also their own, I call it a panel, but their own spaces to speak, so that we will now have a total of 15 witnesses on any given bill. It's particularly important as we head into some really complex bills. Had the cybersecurity bills been ready, it probably would have been useful the other day. The choice bills as well, but it's good. What do they say? Wisdom late is wisdom nonetheless. So with that, I appreciate your understanding, and I'll turn this hearing over to Delegate Penny Melnick.
Thank you, Chairman. Good afternoon, everyone, and welcome to today's bill hearings for the House Health and Government Operations Committee. This is a virtual committee, so I ask for your patience if we encounter any technical or streaming issues. This bill hearing is being streamed on the Maryland General Assembly's YouTube channel. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of 1 question and 1 answer from the panel, not 1 question and 1 answer from each individual panelist. Also, please keep your questions shorter than the expected answer. The bill sponsor or designee is allotted 5 minutes to present the bill. 5 witnesses will each be allowed to speak for 2 minutes in support. Please stay in the hearing until the delegates have had an opportunity to ask questions. Next, 5 witnesses will each be allowed to speak for 2 minutes in opposition and then respond to the question. And in the future, as the chairman stated, there will be 5 witnesses for the favorable with amendment. Please conclude your remarks when you see the timer that is finished, and Richard and Susanna keep the timer, so please be respectful of that. We have a lot of witnesses. Member must remain present with your video camera on during the entirety of the hearing. And the bill order for today, which Susanna has graciously placed them on the chat, are House Bill 627, House Bill 1005, House Bill 684, House Bill 588, House Bill 510, House Bill 609, House Bill 761, House Bill 378, House Bill 370, and the final bill of the day will be House Bill 517. We have today a total of 53 witnesses, so let's be mindful of that time. We are going to start with House Bill 627, which is Delegate Kelly, and the title of the bill is Maryland Medical Assistance Program, Registered Behavior Technicians Reimbursement. Delegate Kelly, will you be so kind and get started? And good afternoon.
Good afternoon, Madam Chairman, and thank you so much for the opportunity to present this bill. Let me start by saying that, and I have never said this before, it is my hope that we don't need this bill. I think there's a letter of information, I believe, from MDH in the file that says that, they prefer to keep this kind of thing in regulation. I do too. So let's start with that. And I have had great conversations with them. I am hopeful that this bill will be withdrawn because the problem will be solved within a week. They've been very helpful to work with on this issue. That being said, I wanted to make sure to present the issue to the committee because I think it's very important and it is timely based on many of the workforce related issues we have been addressing. So I wanted to draw it to the committee's attention in the hopes that we do not need to, in fact, pass this bill. But continue to address this issue with MDH. So the bill is addressing an inequity between families with Medicaid coverage and those with private insurance for ABA therapy for autism. As you know, because we've done a lot of work in this space, applied behavioral analysis, or ABA, is the gold standard therapy for children with autism, and they need it in a timely manner. Last year, we passed a bill to eliminate a mandate that hampered access to ABA therapy by requiring parents to be present for all the hours of therapy. This was a requirement that was only applicable for Medicaid, and it decreased access to care for families, but also serves to inhibit providers from accepting Medicaid patients, which is not a policy we want. This bill actually addresses a different workforce requirement that is, again, only applicable to Medicaid providers and limits their capacity to hire the workforce that they need to meet the demand for ABA therapy. Current regulations require that registered behavior technicians, RBTs, obtain full certification before their services can be billed to Medicaid. RBTs provide support to licensed professionals during therapy, much the way that a paraprofessional does for a teacher in a classroom. They work under the supervision of a licensed behavior analyst. To become an RBT, which is an entry-level position, it's an hourly job, it's intensive, and there's a multi-step process. Applicants have to have a high school degree and complete a background check. They have to then undergo 40 hours of training. After that, they take a skills competency test, which is often called a skill out. Once that skills test is passed, proof of these steps is bundled and sent to a national certification board, which then deems the applicant eligible to sit for the RBT exam. Once they're deemed eligible, the exam must be scheduled and taken and passed, and then the national board issues the certification. It's a highly technical exam, and applicants sometimes do need to retake it, particularly if they are non-native English speakers. And this workforce is often non-native speakers. So even with zero delays in any of the steps, it's a 45-day process. But in reality, it often takes more than double that time to obtain the certification due to delays along the way and various steps in the process. We've heard this story, a lot this legislative session in different health occupation spaces. During the pandemic, MDH actually suspended the RBT credentialing requirement that allowed technicians to provide services before completing, they suspended the credentialing requirement, therefore allowing technicians to provide services before they had completed the entire certification process. This was necessary for making sure that services were delivered during the pandemic. Technicians were able to obtain on-the-job training, which led to increased access to care, increased clinical quality, decreased wait time, etc. Anecdotally, the on-the-job training increased employee retention and exam pass rates. However, the requirement was reinstated in July 2021, which has caused a lot of problems. Wait times for services have increased, particularly for Spanish-speaking families. That's where there's a huge shortage of these RBTs. One Medicaid ABA provider in my district, wait times went from 30 days to 90 days for services once this was reinstated. So what we're trying to do, I see I'm running out of time. What we're trying to do is make sure that we can work out a way that people can get the on-the-job training and not lose their employment while they're going through this process. It's very hard for the employers to find these workers, and we want to support the workforce as they get their training and their credentialing. I just want to note that private insurance does not have a similar requirement and does do it exactly as I described, allow for on-the-job training to get the credentialing. So we really want Medicaid to be able to do that as well. There's some technical amendments, but I don't need to discuss that because what I really want to discuss is that I'm hoping we can work out with MDH in our conversations the next couple of days that they will voluntarily figure out how to do this and we won't need the bill. So with that, I would love to hear from my panel because they can explain to you why we need to make sure that this happens so that our kids get the services they need and the workforce is able to work and be gainfully employed. Thank you so much.
Thank you, Delegate, for presenting your bill. Next, we have Ms. Erin Schaller. Good afternoon.
Good afternoon. Hi, I'm Erin Schaller, and I'm honored to be here to speak as a licensed behavior analyst in Maryland in support of this bill. To start, the RBT is a highly respected credential, given the nature of ABA, regardless of funder. Although a behavior technician may not be an RBT on day one, most agencies expect their techs to become an RBT within 90 days. During this time, per Maryland state law, the tech is always under the close and ongoing supervision of the behavior analyst. Requiring a technician to have their RBT on day one is a huge barrier for staffing, which you'll hear more about, which in ABA, without technicians, clients don't get treatment. This unnecessarily prevents access to meaningful care, and accepting clients without having the proper staffing is a violation of our behavior analyst's ethical code. This requirement 100% prevents appropriate staffing of technicians. In ABA, without a technician, clients don't get treatment. So it's simple. If it takes on average, say 75 days for a tech to obtain their RBT, and that tech must be working hands-on with the client to fulfill their requirements, then staffing a new Medicaid client or finding a replacement is only possible if the new hire is already an RBT. So where I work, only 1 in 5 new techs are an RBT upon hire. That is, there's only a 20% chance that an RBT will be available and the client's treatment wouldn't be drastically delayed or interrupted due to staffing issues. We're all familiar with risk mitigation these days. Is assuming an 80% risk that a behavior analyst is unable to staff a client financially sustainable, or more importantly, ethically okay? This risk does not exist with commercial insurance. It only adds to the already inadequate network of Medicaid providers.
And when does it end? That would be helpful.
Thank you. Delegate Rosenberg, will you be so kind
Sorry.
and mute yourself?
Sorry.
It's okay. It happens to all of us. Thank you. Ms. Schaller, thank you for your testimony today.
Thank
Next, we
you.
have Ms. Judith Rusidi, and I hope I pronounced your name correctly.
Thank you so much. I'm Judith Ursetti, and I'm Vice President of Government Affairs for the Council of Autism Service Providers. And I want to quickly just provide a national perspective related to the issue. The Council of Autism Service Providers is the holder of the generally accepted standards of care related to applied behavior analysis. And in my written testimony, I provided a link to those generally accepted standards of care. This tiered delivery model that utilizes a licensed behavior analyst as well as behavior technicians is critical for access to treatment for people with autism all across the spectrum, whether they need intensive services or those that might not be as intensive. The burdensome requirement that a technician be credentialed on day one when trying to provide services under medical assistance in Maryland is really causing incredible disparity, especially when you look at the way that private health insurance handles the matter. There is no such issue there. So I would ask you just to strongly consider making this minimal change. It's in alignment with generally accepted standards of care. As I said, it's helpful for rural populations, those with complex needs, and it's something that is the requirement now in Maryland is inconsistent with what we're seeing in other states. So we strongly support the passage of this legislation, House Bill 627. And if you have any questions, please let me know.
Thank you so much for your testimony. We appreciate it. Next, we have Ms. Rebecca Rienzi.
Yes, thank you, Madam Chair, members of the committee. I'm Rebecca Rienzi. I'm the Executive Director of Pathfinders for Autism. Pathfinders serves over 20,000 members of Maryland's autism community each year, and I am here today in support of House Bill 627. The requirement is burdensome to providers, as you've heard. It results in a network inadequacy. It also is not clinically appropriate or in line with the standards of practice of care for ABA therapy, as Judith mentioned. And it's not a typical requirement under private insurance policies sold in Maryland. ABA is the common behavioral health therapy that helps people with autism reach their full potential in areas including communication, education, employment, and independent living. Pathfinders hears from families who have had to wait 3, 6, or even 12 months to start services because there are a limited number of ABA providers that take medical assistance. The delay in starting services during early childhood development can adversely impact a child's long-term outcomes. In addition, families with medical assistance report routine gaps in services lasting as long as 3 months because of staff turnover. And this results in the child losing the gains and the life skills that they have achieved. So the cycle of delays and gaps in services for children on medical assistance is yet another example of healthcare inequity that's being perpetuated by Maryland Medicaid. Beyond the issue of equity, the requirement is fiscally irresponsible as it impedes access to treatment that may reduce or eliminate the child's need for special education services and/or adult service programs that are covered by the state. 1 in 49 Maryland children are diagnosed with autism. There are over 13,000 children in Maryland public schools with autism diagnosis. 1/4 of children in Maryland are covered by Medicaid. The math is simple. There are thousands of Maryland children who are experiencing excessive delays and repeated gaps in treatment because they are Medicaid recipients. I urge you to vote in favor of this bill to eliminate that barrier to access.
Thank you for your testimony today. We appreciate it. Are there any questions for Delegate Kelly and her panel? I see Delegate Collison.
Thank you very much, Madam
My
Chair.
pleasure.
Delegate Kelly, am I understanding correctly that what your bill does would allow for that require that MDH pay reimburse under Medicare by allowing these individuals to work for 90 days while working on their certification? And that could help eliminate these gaps in services to students and these long delays?
Yeah, exactly. It's the payments from Medicaid. We want to ensure that during that 90 days that they are able to get their on-the-job training, get reimbursed for the work that they're doing while they get their credential. It is good for the employee, obviously. It's good for the employer who doesn't have to go through that. And of course, most importantly, it's good for the child who needs the services. And it is the model that private insurance uses.
Okay, just wanted to be really clear. Thank you.
Thank you, Delegate. Any other questions for Delegate Kelly or her panel? Seeing none, this concludes the bill hearing on House Bill 627. Thank you, Delegate Kelly. Now we have House Bill 1005, Delegate Smith, Maryland Medical Assistance Program, Community Violence Prevention Services. Good afternoon, Delegate Smith.
Good afternoon, and thank you for having me. It's always great to be visiting with HGO. For the record, I'm Delegate Stephanie Smith, and I'm here to present House Bill 1005. And this is a bill that, really concerns something that I think is on the hearts and minds of many of the people we represent, and that is how can we reduce and prevent violent crime? As many of you know, the city I represent has been hard hit by homicides with the past 7 years consecutively, we've lost over 300 neighbors and family members and brothers, sisters, and community members. And that has a ripple effect that impacts many people. And we're trying to figure out how we can leverage the investments and priorities of the Biden administration around elevating and using Medicaid as a means of standing up a violent prevention services kind of program for our state. So in April of 2021, the Biden administration announced several investments in community violence intervention, and that included investments laid out in the 2021 American Jobs Plan, Medicaid, as well as existing agency funds to develop local programs led by mediators who work with those most at risk of violence and connect them to wraparound services. House Bill 1005 aims to establish, using Medicaid funding, violence prevention services, training, and certification for violence prevention professionals. As we know, when someone experiences violence, it's something that even if you're not the direct victim of violence, even being exposed to violence in the community can have long-ranging impacts, both socially and emotionally. And that trauma is something that also reverberates and can lead to further acts of community violence. When violence prevention programs are efficiently deployed, it connects victims of violence. And these are individuals that oftentimes have difficulty accessing the resources they need to heal. But by healing those that have been exposed to or directly been impacted by community violence, we're not only changing one person's life, you're ultimately protecting an entire community from the ongoing effects of retaliation related to community violence. Per the Centers for Disease Control and Prevention, homicide is the leading cause of death amongst Black males between the ages of 10 to 44 years of age, and is the second and third leading causes of death for Latinx men between the ages of 10 to 19 and 20 to 44, respectively. Many of these individuals are members of low-income households and communities relying on Medicaid or find themselves uninsured and unable to find resources to heal. Of our nation's 50 states, at least 19 of them have a violence prevention program like the one we aim to establish right here in Maryland. The Center for Medicare and Medicaid is ready and able to provide technical and financial assistance to the state of Maryland as we work to establish this program. Just wanted to highlight what it means to create a certification program. This bill would direct the Maryland Department of Health, MDH, to approve at least one accredited training and certification program for certified violence prevention professionals. And this would be at least 35 hours of initial training and at least 6 hours of continuing education every 2 years. And those professionals that would be certified pursuant to this law would also be able to render services to Medicaid recipients who have, one, been exposed to community violence or have a personal history of injuries sustained as a result of an act of community violence, and have also been referred by a healthcare provider or social services provider to a certified violence prevention professional. So I do hope in our mutual interest to not only reduce violence, but to ultimately prevent violence from being an outcome in our communities. I do hope that the committee will render a favorable report for House Bill 1005, and I do thank you for your time today.
Thank you for your testimony. We appreciate it. Next, we have Ms. Martha Nathanson. Is she in?
Yes, I am here.
Okay.
Yes, can you hear me?
Yes, we can.
Very good. Thank you, Madam Vice Chair and members of the committee. Yes, I'm Martha Nathanson, Vice President for Government Relations and Community Development at Lifebridge Health. I wanted to connect this violence intervention programming to our community health needs assessment, which you are all familiar with as a requirement as part of the Affordable Care Act. Each year, every 3 years, we do a community health needs assessment, which is a very broad-based, deep assessment process with our communities. And since 2015, in 2015, 18, and 21, our triennial cycles, we have heard from our communities that in addition to the usual suspects of diabetes and heart disease and cancer, that food access and violence intervention, violence concerns were primary in terms of the way people felt that their health care would be, their health outcomes would be impacted. So beginning in 2015, we did a major expansion of our community violence programming. We increased our staff from 36 to 85 for our violence programming overall. And unfortunately, these types of programs are dependent upon grants and philanthropy and operating revenues. And so having a steady stream of revenue from the Medicaid program will help us ensure that we're able to maintain this and to expand it. Clearly, hospitals treat victims of violence, the very folks that Chair Smith spoke about. We treat them already, especially in our most expensive settings of the ER, the ICU, surgery, and rehab. And as a level 2 trauma center, one of our hospitals, Sinai Hospital, sees these kinds of patients all the time. And we know how much these cost, and the potential for savings, I think, makes the argument for passage of this bill and for allowing for Medicaid reimbursement for these complex patients. One quick note before I close, there are several concerns about the fiscal note. We're looking into this. They came up during the Senate hearing. One is that the number of patients who might qualify for these types of community violence intervention, this type of coverage, has probably been overstated in the fiscal note. We're looking into that, and we'll have some more data for you when this goes to subcommittee for further discussion, if it does. The total could be as little as $350,000 and maybe $1 million in terms of costs, because we haven't yet been able to calculate the potential savings. So we are going to work on that and hopefully have that for you. And either way, what a small cost to ensure professionalism in this area for providers, as well as continued available funding to help us be able to serve the need that our communities identified in the assessment. And with that, I'll close and happy to answer any questions. Thank you so much.
Thank you. Thank you for your testimony and your expertise. Next, we have Ms. Lisa Jones.
Good afternoon, Madam Vice Chair and
Good
Committee.
afternoon.
I'd like to share, I am the Director of Community Violence Intervention Programs for Center for Hope, which is a Lifebridge program. I currently supervise 2 hospitals where there's hospital responders, 2 Safe Street sites, and PAVE, which is a program that helps young people and families who have been victims of gunshot wounds or severe violence. I want to share a quick story with you so that you can see how these programs work. There was a young lady who was a high-ranking member of a gang. She saw her brother killed on the street and another dear friend sent to the hospital who was wounded. A hospital responder met with the person who was shot at the hospital and did case management to mitigate more violence. The responders on the interrupters on the street worked with her around the clock. They worked with her so much so to help plan the funeral, to prevent more retaliation. They worked with her so much, she became an advocate for the program. In doing changing her life, as a result of her advocacy, she stopped the violence that could have been potentially active in the community because of her influence with the gang affiliation. As a result of her connection and relationship with the interrupter, she then changed her life and became a staff and interrupter herself, thus mitigating the potential for more violence because of her influence in the community. Because of the trajectory that was changed, many lives were saved. Because of the trajectory that was changed, the violence was mitigated in the community that she had influence. Because of this, it is critical, it is extremely important for the House to support Bill 1005.
Thank you so much for being with us today. Next, we have Ms. Shantae Jackson.
Thank you so much, Madam Vice Chair and members of the committee for hearing me today. My name is Shantae Jackson, and I'm the Director of the Mayor's Office of Neighborhood Safety and Engagement in Baltimore City. On behalf of Mayor Scott and the Baltimore City Administration, we offer our strong support of House Bill 1005. I also serve as Mayor Scott's liaison into the White House for the Community Violence Intervention Collaborative, and want to share that it's our position that Maryland should be on the forefront of expanding hospital-based services to prevent and intervene in violence in our communities, because we know that injured patients are at acute risk of being either re-victimized or becoming perpetrators of violence themselves. In Baltimore City, we've already demonstrated that these programs can be cost-effective in preventing fatal re-injury. With the University of Maryland Medical Center, we were able to implement what was called Stop the Revolving Door phenomenon, where we saw patients be discharged without counseling or services, only to see them get readmitted all over again for serious injuries. Just at the beginning of this month, my office, along with the Health Commissioner, Police Commissioner, the U.S. Attorney for the state of Maryland, and the mayor, met with all of the chief medical officers for every medical system here in Baltimore City. And we received their staunch support along with ours in presenting to you that we've got to take this time to actually partner so that we can expand the services necessary to drive down violence, not just in Baltimore City, but violence in the state of Maryland as a whole. Medicaid's not just a new source of stable funding for us. Mayor Scott has committed to a public health approach to violence and looks for you all to stand with him to support him with regards to House Bill 1005. Thank you so much.
Thank you for your work. Next, we have Mr. Brian Sims.
Good afternoon, Vice Chair Pena Melnick and committee members. Can you hear me okay? Okay.
Yes.
So I want to thank my dear friend, Delegate Smith, for bringing this really crucial bill to the committee. My name is Brian Sims, Director of Quality and Health Improvement at the Maryland Hospital Association. And on behalf of our 60-member hospitals and health systems, I appreciate the opportunity to comment in strong support of House Bill 1005. You know, as you heard some of the partners here today, community violence affects thousands of Marylanders every year, and the deep physical and mental wounds that violence leaves behind is a major public health problem. And you just heard Ms. Jackson talk about the public health approach here in Baltimore City. And while hospitals play an important role in caring and providing care to victims of violence, The ending the cycle of violence is a priority that we share with the many community-based organizations that have been engaged in prevention efforts for decades. Hospital-based violence intervention programs and community violence intervention programs are critical in this fight and must be adequately funded to meet the needs of the community. Now, beyond individual well-being, community violence adds immense economic costs to the health system. And this cost far exceeds the cost of prevention initiatives, which you heard Ms. Nathanson reference earlier. Medicaid is often financially responsible for the state's high costs, high levels of community violence, and the integration of violence prevention programming in the traditional healthcare and financing systems would represent a significant shift in the state's response to community violence. And so the need for community violence prevention funding cannot be overstated. We know what things work to stem violence in our communities, and like strategies that we saw employed during the COVID-19 pandemic, a well-funded public health approach is necessary. And now is the time really to adopt sustainable long-term solutions to address community violence and help our communities heal and attempt to break the cycle of violence. And so for these reasons, we strongly urge a favorable report on House Bill 1005. Thank you.
Thank you for your testimony and your work. Are there any questions for Delegate Smith and her panel? And you can go to the reactions icon and raise your hand if there are any. I see Delegate Robin Lewis.
Thank you, Madam Chair.
My pleasure.
Thank you so much, Delegate Stephanie Smith. Thank you so much for bringing forward this bill, and thanks to the panelists for your supportive testimony. I want to say that first that we talk a great deal in this committee about the connection between public health and a public health approach to violence prevention. But my impression is that this bill really takes that statement literally by making public health prevention, which is paid for by Medicaid, part of a violence prevention strategy. It really makes that real. So thank you for that. I was wondering if the bill sponsor could talk a little bit more about the connection between training violence interrupters and health outcomes, or if not the sponsor, then perhaps someone else. Talk a little bit more about the connection between training violence interrupters and health outcomes. Could you make that a little bit more clear? Because it's not necessarily.
Delegate, I would like to defer to Director Jackson. I believe she might be best poised to talk about the training broadly. Is that okay, Director Jackson?
Absolutely. And I don't know if Dr. Fisher has joined us here. I'm seeing Brian shake his head no. He's probably the best person to answer this question, given his long tenure with the Health Alliance for Violence Interrupters, or the HAVI program. But what we do know, Delegate Lewis, is that there is a direct correlation to the development and training that we provide for our community violence intervention workers, both in a hospital-based setting and on an on-the-ground setting with regard to their level of effectiveness around life coaching for individuals. In particular, life coaching is something that we aren't necessarily doing as well as we could be doing, not just in the state of Maryland, but across the country, which is one of the reasons why the Civic was established by the Biden administration. In addition to that, this victim services piece, where we're providing the full wraparound supports and making sure that there's a level of connectedness to service, those things come as direct learnings, if you will, from this certified level of training that folks would be going through as a part of this recommended bill. It also allows them for different career trajectories themselves, given the trauma, the vicarious trauma, the complex trauma that they deal with in being those first responders every single day in the most egregious cases that we see in our city. So I would say that it's multifaceted in that it is providing victims the supports that they need, but also a career trajectory for folks who have historically been exposed to trauma themselves as pathways out.
And Delegate, if I may add, I'm so glad we didn't even coordinate that, Director Jackson. That was just, organic. But I just want to add that what she said at the end is really important. Someone that has the credibility.
Is that okay, Madam Chair, if we have?
Yeah, we usually.
Oh, I apologize.
We usually just allow one person to answer.
No problem.
May I ask the sponsor to?
You can ask a quick follow-up, okay?
Thank you, Madam Chair, to the sponsor of the bill, if you would kindly add anything else we think we need to know.
Yeah, just quickly, it's important that those that have the credibility to be influential to disrupt and prevent violence also have a career path so that they can continue to grow and grow the economic base of their community. So I just wanted to re-emphasize that point.
Thank you. Thank you, Madam Chair.
My pleasure. Any other questions for Delegate Smith? Delegate Smith, I have a question. And I was wondering if you saw the letter from the Anne Arundel County, Maryland Department of Health.
No,
And
I did not.
If you haven't, I will make sure I'm going to have my team send it to you. So I don't want to put you on the spot, but there are 2 questions in there. They are very supportive of the bill. It's a great idea. I mean, it's about time. But there are 2 questions in there that they like address. And one of them is, he says there are many challenges moving non-clinical services into a fee-for-service reimbursable rate. How would the state address these challenges? And the other one is, will the state develop or assign a credentialing body that can determine who can employ these specific positions for reimbursement and payment? So if if you could offline think about those and with your best experts and send us a little memo or something, okay? And I'll make sure my staff sends it to you. Thank you. Any other questions for Delegate Smith? Seeing none, Delegate Smith, thank you for being with us today. We appreciate your testimony.
Thank you for having me.
Have a blessed day. Thank you. This concludes the bill hearing on House Bill 1005. Next, we have House Bill 684, Delegate Bagnall, and it's the Maryland Medical Assistance Program, Psychiatric Inpatient Care, Admissions Restrictions, Psychiatric Hospital Admissions Equity Act. Delegate Bagnall, good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnall, District 33, Anne Arundel County, here on behalf of House Bill 684, the Psychiatric Hospital Admissions Equity Act. Colleagues, one of the consistent threads in our work in this committee is equitable health policy, irrespective of economic status. I have worked on numerous bills to ensure equitable services for behavioral health treatment and care for our most vulnerable populations. So you can understand my concern when I learned of a policy which required hospitals to make multiple calls to acute care facilities for low-income crisis patients before transfer to a specialty psych facility. The policy was, in fact, a carryover from the Institutes of Mental Disease Medicaid exclusion established in 1965. This exclusion, which attempted to shift federal costs to the states and move care from large facilities to community-based services, had the unfortunate consequence of closing nearly 97% of state psych facilities, leaving a critical lack of crisis services nationally, which is why, following the enactment of the Affordable Care Act, a recent agreement was reached with the federal government in the Health Choice Waiver renewal application, and Medicaid requested coverage for inpatient stays for patients at an Institute of Mental Disease, rendering the need for such a policy not only unnecessary, but stigmatizing and discriminatory. It is imperative that decisions made around medical care are based on medical necessity and clinical rationale. Medicaid admissions to IMDs have been limited in the past to account for economic impacts rather than based on medical criteria. Additionally, although the policy is not currently enacted, the Maryland Department of Health's previous policy of calling meant longer wait times in emergency departments for our most critical, vulnerable patients, delays and setbacks for Medicaid patients who need imminent, specialized psychiatric care. As the understanding of mental illness care and treatment has advanced, we need to ensure that we aren't creating additional, unnecessary, non-medical barriers to the most appropriate and effective care that leaves our most acute patients languishing. The COVID-19 pandemic has created a monumental need for all healthcare, including mental and behavioral health care, And this bill will ensure that no one is denied adequate, appropriate, and prompt care on the basis of economic obstacles. House Bill 684 will make clear the intention of this body that policies and/or restrictions established by the Maryland Department of Health for inpatient admissions at licensed psychiatric hospitals are based on criteria of medical necessity. These policies may not be in place at this time, but without HB 684, there are no measures to prevent the same or similar policy from being reinstituted in the future. Further, the department must implement any such criteria through COMAR regulations. This legislation will help protect some of our most vulnerable populations here in Maryland. You will see in your packet broad scale support from our provider community, from the hospitals, and there is no opposition. And for all these reasons, I respectfully request a favorable report on House Bill 684.
Thank you, Delegate, for your work. We have next on your panel, Dr. Harsh Trivedi.
Good afternoon, Madam
Good
Chair.
afternoon.
Madam Chair, Madam Vice Chair, members of the House Health and Government Operations Committee, thank you for the opportunity to testify in support of House Bill 684. I especially want to thank Delegate Bagnell for her leadership and for crafting this legislation. She has covered all the salient points. What I wanted to do was to focus on what exactly does this bill do? The policy that the delegate described, how it impacts equity, how it impacts people access and care, is that when someone goes to the emergency room, they're seen by an emergency room doctor, they have an assessment, they're evaluated, and there's a decision made that says, well, yes, this person needs to come into the hospital. The policy that was being referred to was one where if you had a commercial insurance, that emergency room doctor would be able to pick up the phone, find where there is a bed available, and immediately admit the patient based on medical necessity alone. The policy that was referred to through MDH was one where if that person had Medicaid as their insurance plan, what the emergency room would have to do was to get 5 denials from 5 general hospitals before a patient could be referred for admission to Shepherd Pratt or to Brook Lane for often beds and services that don't exist anywhere else, or the capacity doesn't exist in that moment. This is inequitable for the population that we're talking about, which is the IMD population. To this day, life expectancy is over 20 years shorter in this population. And all this bill seeks to do is to allow the same access to medical care as we afford to every other citizen within the state of Maryland, and that any one of us would expect to get if we were there. Thank you so much, and I respectfully ask for support of House Bill 684.
And thank you, Doctor, for the work you do in our community. We appreciate it. We have next Ms. Jennifer Wilkerson.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. Thank you for the opportunity to testify today in support of House Bill 684. Shepherd Pratt serves patients across the entire state, as well as patients who come to us both from almost every other state and many different countries. The hospital offers psychiatric services that are not widely available anywhere else in the state, or in some cases, even anywhere else within the country. The Maryland Healthcare Commission has recently cited need for services for underserved populations. And in many cases, Shepherd Pratt is one of the only providers, or the only provider, that has these services within our state's behavioral health care system. In the absence of these services provided by Shepherd Pratt, many of these individuals would end up in emergency departments or not receiving treatment at all. Because Shepherd Pratt is able to provide these services, it can support hospitals across the state by relieving pressure on emergency departments and psychiatric units that often don't have the capacity or the capability to manage these behavioral health care patients. All of Shepherd Pratt's efforts are contingent, however, on having the resources and necessary funding to provide these types of services. This legislation removes potential barriers to patients trying to access Shepherd Pratt services and ensures that we are able to invest in providing and expanding our ability to serve these populations that would otherwise go untreated. Shepherd Pratt is committed to its mission of improving the quality of life of individuals and families, And this legislation helps us further that mission by ensuring that patients are able to access our services when they need them. I respectfully request a favorable report. Thank you.
Thank you so much for your testimony, for everything you do, and for taking my calls when I call you on Saturdays and Sundays. I have now Mr. Todd Peters, Dr. Peters.
Madam Chair, Madam Vice Chair, and members of the House Health and Government Operations Committee, thank you so much for letting me give me the opportunity today to testify in support of House Bill 684. We at Shepherd Pratt and in the mental health field are truly grateful for your leadership and support of behavioral health treatment in the state. My name is Dr. Todd Peters. I'm a psychiatrist and also the Chief Medical Officer at Shepherd Pratt. I'm also very pleased that at Shepherd Pratt, despite this very challenging time that we're in, was able to open up a brand new behavioral health treatment facility in Elkridge in June of 2021. This hospital includes 85 inpatient beds, 4 specialized outpatient programs, a psychiatric urgent care program, and a neuromodulation program. We've been really proud that during this time, and we've been able to keep all of our inpatient units open between both of our hospital campuses, and really been able to treat Marylanders in need, even those that were COVID positive, and allowed them to get ongoing psychiatric care throughout the duration of the pandemic. We've been able to keep our crisis and outpatient services open in full and really expand what we do both in person and virtually during this time. We know that our work really provides life-saving treatment to those most in need, which is why this bill is really important. As stated very eloquently by Delegate Bagnall, the legislation before you looks to really erase an administrative policy that tends to trump medical necessity and what we know is right and what we know allows people to access services. This 5 denial rule causes people to wait unnecessarily in emergency rooms, often which are not equipped to house patients for days or weeks on hand. They're oftentimes in basements with no windows and really provide inadequate care that we know that we can provide in our inpatient facilities. And so decreasing this administrative burden to allow people to get the care they need when they need it is of utmost importance. As a doctor, I treat all patients to the best of my ability, and this new bill will help us to do that. So I respectfully request a favorable report on House Bill 684. Thank you.
Thank you for your work and for being with us today. Next, we have Mr. Jeffrey O'Neill.
Thank you, Madam Chair, Madam Vice Chair, and members of the Health Government Operations Committee for this opportunity to also speak in favor of House Bill 684. I'm Jeff O'Neill, the Chief Executive Officer of Brooklane. We're a 57-bed specialty psychiatric hospital with a full continuum of outpatient services as well.
So grateful to you.
We're located out in rural Western Maryland, and we serve all ages. We are the primary referral source for inpatient psychiatric care for all of the acute care hospitals in the Panhandle. And although we do receive referrals from all around the state, acute care hospitals are experiencing the serious challenges my colleagues at Shepherd Pratt have identified with boarding patients in the emergency departments. And Brooklane, with its 57 beds, is well positioned to help ease this burden. This process works generally well for the commercially insured patients, but that different standard does exist for those patients who are Medicaid beneficiaries because of the 5 denial rule. Based upon that, this creates a blatant disparity in care, as Medicaid recipients are more likely to experience a much longer delay in the hospital emergency rooms while the 5 denials are secured. Brooklane is also proud to say that more than half of our patients are Medicaid recipients, and they deserve the same level of care as everyone else. This legislation removes the barriers for Medicaid patients to access specialty hospitals, restores healthcare equity for all, and accessing inpatient psychiatric treatment, and addresses the delays and challenges of the acute care hospitals in moving patients out of their emergency departments to the appropriate level of care. So on behalf of Brooklane and our most valuable most vulnerable patients in Maryland, I also respectfully request a favorable report on House Bill 684. Thank you for the opportunity to speak.
Thank you. Our pleasure. Seeing all the witnesses, are there any questions for Delegate Bagnall and her panel? I see Delegate Hill. You have to unmute yourself, Delegate Hill.
Okay, try that
thank
again.
you.
Thank you, Delegate Bagnell, for this great bill. And thank you all for being here. I wanted to ask Dr. Treveda, unless he left, so maybe one of the others can answer. This 5 denial rule for Medicaid beneficiaries. So they're getting denied 5 times before. What happens, and how does that serve, or how is that supposedly serving the CMS rules for payment of Medicaid? It doesn't make sense. It's been going on a long time. I'd really like to understand why MDH thinks this is an important thing for us to do.
Sure. So thank you for the question. What I would say is, I think in general, what this bill hopes to do, as Delegate Bagnell had said, was to really prevent MDH from erecting this or future barriers to people accessing care. In this particular situation, what it does is it creates a barrier in which essentially the emergency room has to call a general hospital to attempt to find an open bed somewhere. And I think the rationale is that if you put in this barrier, there will be some portion of patients who get admitted to a general unit and not an IMD. And I think from an economic perspective, if admitted to the general hospital, the state does receive the federal share dollars. Now, what I will tell you is that there isn't a number you can put on essentially what is the cost to the person who is a Medicaid beneficiary in terms of languishing in that emergency room for 72, 96 hours or more. As was mentioned in terms of, I will say, the phone calls we get Friday, Saturday, Sunday, most any night from many of you. We are wanting to get people into the hospital. We're here to say yes. And it truly is an economic issue, and particularly when this legislature is focused on equity and ensuring health equity. This is one of the things that if I was a Medicaid recipient and I knew that it was a 5-day, 7-day, multiple week wait in an emergency room, I wouldn't show up for care the next time. And that really is not fair to our most vulnerable, who are also often at highest risk for adverse outcomes.
Thank you. Madam Chairman, I have a brief follow-up.
Yes.
Thank you. So for clarification, there may be a bed available in a specialty hospital that would serve the patient, but they're not allowed to go there until they're told that a less expensive option is unavailable 5 times. That's what that rule essentially requires.
Yes, and I'll add to that by saying we are actually, as a specialty hospital, not more expensive. We're actually in the lowest 10th percentile of all hospital costs when you look at inpatient psychiatric beds across the state, and these are published HSCRC rates. So not only are we not more expensive, we also have available beds, and that's part of the issue. And what we want to do is prevent other arbitrary policies from coming into being, simply to direct flow of patients, which really should be where the bed is available. We should get people in for care as soon as possible, because a psychiatric crisis is just as important as a medical crisis.
Very good. Thank you very much. Thank you, Madam Chair.
My pleasure. Are there any other questions for this panel? Seeing none, this will conclude the bill hearing on House Bill 684. Next, we're going to go to Delegate Bagnell, House Bill 588, Local Health Departments and Community Action Agencies, Feminine Hygiene Products. Delegate Bagnell.
Thank you once again. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnell, District 33, Anne Arundel County, and I'm here testifying on behalf of HB 588, Local Health Departments and Community Action Agencies, Feminine Hygiene Products. You have my written testimony, so I'll summarize. According to an article in The Independent, there are over 5,000 slang terms and euphemisms for the very natural process of a menstrual cycle. So it is no wonder that it is so hard to talk about something so stigmatized when we can't even have a conversation about our period. You may recall this bill from last year, and my extraordinary young advocate, Ms. Khan, who took up period poverty originally as a Girl Scout project, giving jaw-dropping testimony before this committee. Menstrual health is an equity issue. According to the Period Project, each year, people in the United States spend more than $2 billion on menstrual hygiene products. We have taken great strides in Maryland to ensure greater equity when it comes to menstrual health, eliminating the luxury tax, requiring access to menstrual products for our incarcerated communities, our homeless shelters, requiring schools to supply no-cost menstrual products to students, tax incentives for donations, but we have no state or federal mechanism to ensure delivery of menstrual products for our low-income, most underserved populations. Federal programs such as WIC and SNAP have extensions for essential medication, but not for menstrual products. Health savings programs allow for a deduction for menstrual products, but are only available through private insurers. According to a research report in obstetrics and gynecology, more than 1 in 5 women in a major US city couldn't afford menstrual hygiene products. Poor menstrual hygiene can cause serious health risks, such as urinary tract infections, reproductive tract infections, and infertility, and is a major contributing factor to the development of cervical cancer. Additional lack of this basic need can result in embarrassment, shame, mental distress, as well as loss of work, loss of wages, and loss of dignity. HB 588 seeks to address a gap community of low-income people by working with community action agencies who already have a strong foothold in those communities, and in collaboration with local health departments to provide no-cost menstrual health products. Modeled on federal legislation, which has not yet passed, 588 would establish a pilot program which would distribute menstrual products in 2 to 3 areas, which will work to establish the framework for the need and distribution throughout Maryland in the future. I have continued to work with the Maryland Community Action Partnership and Maryland Association of County Health Officers. And at the recommendation of our stakeholders, we have an amendment, which should be in your package, which reduces the program to a pilot, removes the local health departments from the administrative role, and addresses the budget language to ensure we do not create an unfunded mandate. And you will see in your packet, we have no opposition to the pilot as proposed. We are still working with MCAP to identify the regions that would be most successful for the pilot, and which will also give us our calculation to clarify the state allocation. Additionally, we've spoken with the Maryland Department of Health to ensure that MDH will work in collaboration with MCAP on the implementation plan and execution to ensure that we're setting up a program for success, recognizing the unique needs and challenges of our communities and providing the flexibility for the various community action agencies who will participate. Period poverty is real. This is an issue of equity, dignity, and humanity, and we have an opportunity to once again be a leader in Maryland, to create the framework to serve our state, and to address a federal allocation should that bill pass in the future. And for all these reasons, I am asking for your favorable report on HB 588.
Thank you very much, Delegate, for your testimony today. Next, we have Ms. Angela Martin. Good afternoon, Ms. Martin.
Good afternoon. Thank you, Madam Chair, and good evening to the committee members and to the Vice Chair. As I'm with Maryland Community Action Partnership, we serve as the united voice for community action agencies across the state. And at the core of our mission is eliminating barriers hindering economic security. And period poverty is one of those barriers. This is a financial burden to women who are experiencing poverty. As been mentioned, Delegate Bagnall mentioned research around this. One of the facts that's been researched is that almost 2/3 of women in the U.S. with low incomes could not afford menstrual products in the last year, while nearly half of those sometimes had to choose between buying food and menstrual products. Well, women shouldn't have to choose between buying food and feminine products. So we support this legislation. Feels as if it exemplifies a best practice in making feminine hygiene products available to women with low income. Meeting this basic need will contribute to the foundation that Marylanders with low income need to fully engage with and thrive in their educational, employment, and endeavors to build a better future for themselves and their families. We believe that everybody deserves to live with decency and with dignity. So we urge your support of this bill, of House Bill 588. Thank you.
Thank you, Ms. Martin. Next, we have Ms. Rashida Jameson.
Hello, Madam Chair.
Good afternoon.
The fact that a bill of this nature is even needed shows the state of vulnerability for low-income women. United Communities Against Poverty, we manage the largest women and children's homeless shelter in Prince George's County. We also manage one of 3 diaper banks in the county, and we also manage an emergency food bank, which also is a bulk food bank for smaller inside the Beltway food banks as well. And of these 3 programs, the participants request not only the resource they're seeking, but also the necessary menstrual products that are needed. For women, these basic necessities go beyond food and housing, and it includes the lack of access to sanitary products due to their financial constraints. This is an invisible form of poverty, and it affects low-income women across the state. HB 588, if passed, would provide access to these products and would aid women in addressing a simple, basic necessity, while also requiring the governor to include funding in the annual budget, and an amount estimated to be sufficient for providing feminine hygiene products to women enrolled in the Maryland Medical Assistance Program. As a provider of an emergency homeless shelter for Prince George's County, UCAP wholeheartedly supports HB 588. We know the firsthand need and the burden it costs on women experiencing poverty. Thank you.
Thank you for your testimony, Ms. Jameson. Now we're going to open it up for questions. Are there any questions for this panel on House Bill 588? I don't see any. 1 second. Okay, I don't see any questions. So this will conclude the bill hearing on House Bill 588. Thank you for being with us today. We appreciate your testimony. Next, we have House Bill 510, Chairman Pendergrass. The title is Healthcare Facilities, Health Services Cost Review Commission User Fee Assessment. Good afternoon, Chairman.
Thank you, Madam Chair.
My pleasure.
I'm going to just turn this over to the experts on this, either Katie Wunderlich or Megan Renfrew, whoever is planning to go first.
Thank you, Madam Chair and Madam Vice Chair. My name is Katie Wunderlich. I'm Executive Director of the Health Services Cost Review Commission, and I do have Megan Renfrew, Associate Director of the HSCRC, online as well. We are here to present House Bill 510 for your consideration, which is a Health Services Cost Review Commission user fee assessment. First, I do want to thank Chair Pendergrass for sponsoring this legislation, and also thank the committee for considering and hearing this bill proposal. HB 510 supports the ongoing and sustainable operations of the HSCRC by changing the methodology for calculating the Commission's user fee assessment cap in a way that will provide the Commission with the budget it needs to continue its critical work supporting the Maryland health model. Specifically, the bill change would amend the user fee from a flat $16 million per year cap to the greater of 0.1% of budgeted regulated gross hospital revenue, or the largest amount of the cap for a fiscal year in the 5 preceding years. As you know, HSCRC is an independent state agency responsible for regulating the quality and cost of hospital services in the state to ensure that all Marylanders have access to high-value healthcare. Our vision is to enhance the quality of that care, improve patient outcomes and experiences, improve population health, and reduce the total cost of care in Maryland. HSCRC does play a crucial role in administering and advancing the Maryland Health Model, also known as the Total Cost of Care Model. It brings with it a number of key benefits to the state, including but not limited to cost containment for the public, improved quality outcomes, investments in population health and health equity, a focus on primary care, equitable funding of uncompensated care, and support for state health infrastructure. HSCRC staff, expertise, and analytic capabilities have expanded and are crucial to supporting the goals of the model and to ensure that those key benefits continue. Just as an example, some of the ways that we have gone beyond just hospital rate setting duties, we do facilitate partnerships between hospitals and their community-based organizations to tackle population health and health equity. We are tasked with developing voluntary programs for physicians, both primary care and specialty physicians, to engage in value-based care to improve health outcomes, quality, and reduced cost. And finally, absolutely still have that responsibility to monitor ongoing health and capacity of hospitals, of the hospital system. The HSCRC also provides valuable expertise to the legislature through legislative assigned reports and tasks. In our written comments, we've included an appendix that includes the reports and tasks that we have accomplished for the General Assembly over the last few years, including but not limited to medical liability, facility fees, medical debt, and behavioral health. And so we absolutely support the goals and the aims of the state legislature and provide any analytic expertise or guidance that we can in the endeavors that you all have to direct healthcare in Maryland. We believe that this request to change the user fee assessment is timely. We have not had our last user fee cap adjustment was in fiscal year 18. In the past, the cap has been revised every 3 to 4 years. And so we have gone a full 5 years without an adjustment to the cap. So this is a timely adjustment, and one that is tied to the commission, the industry that we regulate. As you know, the total cost of care model requires Medicare savings and requires the state to constrain the growth of hospital all-payer revenue. And so in tying our commission budget to regulated patient revenue, that does ensure that there is a regulated and controlled rate of growth for not only the healthcare industry that we regulate, but also for the commission itself. I appreciate the time that the committee has given to this bill, and I'd be happy to answer any questions.
Thank you so much for your testimony. Really appreciate it. Ms. Megan Renfrew.
I am actually just here to answer questions. So
okay.
Don't need any time.
Wonderful.
Thank you.
Thank you. Are there any questions? 1 second. I have a question from Delegate Robin Lewis.
Thank you so much, Madam Chair. Thank you, Ms. Wunderlich, for your testimony on this bill. Is it the routine practice for this user fee to be increased at a regular basis? Is it considered abnormally long time since the last increase?
So I would say, thank you, Madam Delegate, for that question. Yeah, so user fee and special funded commissions such as ours do have regular updates to their fees just to keep up with inflation. We have, as I mentioned, and in our written testimony, our most recent one was in fiscal year 18. We had an adjustment in fiscal 15, fiscal 12, and fiscal 8. So it's been about every 3 to 4 years. So this does represent the longest span of time that we have gone with a flat, stagnant assessment. And I would argue that this is also the time where we have undergone the most change in our healthcare delivery system and our model.
Understood. Thank you. And thank you for all the work you do. I heard you mention medical debt. I know that was a lot of work and I appreciate it. Thank you. Thank you, Madam Chair.
Thank you. So, Katie, you can either choose to answer it now or later on, offline, or in subcommittee. There is a letter from the Maryland Hospital Association. Have you seen it? So how will you address the second paragraph that it says that this creates a situation where the HSCRC assessment on hospital can grow even when hospital revenue is falling, and without the consent of the General Assembly, this will give you a unique authority as a state agency to raise fees automatically. So they seem to express concern.
Sure, absolutely. And I'd be happy to continue to talk about this in subcommittee, but just as a very brief and quick response to that, the HSCRC operating budget is subject to annual appropriation and annual oversight from the General Assembly. So every year we come into the Budget Committee to review our budget, as all state agencies do. So this does not change in any respect that legislative oversight over our budget. And it also would not let us raise fees indeterminately. We would peg it to 1/10%. We have put on that safety valve of a 5-year look back, but that really is in case there is some a pandemic, other things that really throw a wrench in. And of course, the Health and Government Operations Committee, we are in front of regularly, and we'd be happy to continue to come back to HGO. But in terms of the legislative oversight, we do every year. The Budget Committee oversees and approves the budget, and the General Assembly with the budget package.
Thank you so much for addressing that. Are there any other questions for House Bill 510? Seeing none, this concludes the bill hearing on House Bill 510. Thank you, Chairman, and your panel. Next, we have House Bill 609, and House Bill 609 is Delegate Peña-Melnick and Chairman Pendergrass. The title is Local Health Officers, Removal Grounds and Process. So I will get started on it. So that this legislation is necessary is an unfortunate reflection of the undue political influence we have seen in our public health policy. Since the COVID-19 pandemic began, public health officials have increasingly become political targets. They have experienced retaliation from elected officials, as well as vital harassment and even threats of violence from the public. Currently, according to Maryland state law, a county level health officer is nominated by the county council, and after the appropriate qualifications have been established, appointed by the Secretary of Health. These qualifications include that all such nominees should have a master's degree in public health and at least 2 years work in the field, or at least 5 years work in the field. House Bill 609 changes none of these procedures or regulations. What it does do is regulate the process of removal of county health officers by providing clear grounds for removal and making the removal process more transparent so as to avoid political influence. It basically gives notice and due process. If enacted, House Bill 609 would establish the following as acceptable grounds for removal of a county level health officer: immorality, misconduct in office, insubordination, incompetency, or willful neglect of duty. Additionally, it will require that if the secretary and the governing body concurred on the removal of the health officer, then the secretary shall provide written notice to that person, including the basis of removal, which must be subject to the appropriate grounds, as I mentioned. House Bill 609 also provides the removed health officer the opportunity to request a public hearing on the matter within 10 days after the secretary sends the notice of removal. If the public hearing is requested, it must then be promptly scheduled by the secretary. These common sense measures will ensure transparency in our public health policy so that Marylanders can be assured that if the health officer is removed, it has been for appropriate reasons. Now more than ever, it is imperative that we guide our policy by science and ensure that our well-qualified health officers have some level of insulation from our political divides. It could very well be a matter of life and death. I respectfully request a favorable ruling, a favorable report on this legislation. Thank you. We have as witnesses, Mr. Larry Polsky.
Madam Vice Chair, Madam Chair, members of the committee, my name is Larry Polsky. I'm here on behalf of the Maryland Association of County Health Officers in support of HB 609. The goal of HB 609 is to better insulate health officers from increasing outside pressures so they can base health decisions on the best scientific and medical information available. In an age where public opinions are swayed by social media content filled with questionable and at times erroneous health information, has become ever more important to provide a buffer for health officers who answer not only to elected officials, but to the professional and ethical standards of the boards of physicians and nurses. Events of the past 2 years have demonstrated that health officers operate in a different arena than most appointed officials. County government directors who serve at the pleasure tend to oversee inherently political departments, such as planning and zoning and economic development. But regardless of public opinion polls, viruses will continue to spread, failing septic systems will pollute our waterways, fentanyl will cause overdoses, and salmonella will trigger outbreaks. Health officers are also duty-bound to carry out state regulations and orders from the Secretaries of Health and Environment that don't always sit well at the local level. In order for health officers to consistently and effectively protect the public's health, we need an extra safeguard against termination solely because our professional duties conflict with local preferences. HB 609 is not intended to marginalize elected officials or to make it impossible to remove health officers. An objection from the opponents of the bill is that you're not able to remove health officers even in situations where they disregard local or state guidelines. This should not be a concern. HB 609 allows removal for neglect of duty, lack of competency, and misconduct. These are broad categories and should provide reasonable grounds for dismissal in almost any situation where a health officer fails to properly fulfill her or his responsibilities. In conclusion, in an era of lost expertise in the public sector, HB 609 will provide stabilization where health and lives literally hang in the balance. The Maryland Association of County Health Officers thanks the bill's sponsors and asks for a favorable report. Thank you.
Thank you, Dr. Polsky. We appreciate your testimony. Next, we have Ms. Kathleen Hoke.
Good afternoon, Madam Chair, members of the committee. I'm Kathy Hoke, and I'm a professor at the University of Maryland Carey School of Law, where I teach and practice public health law. I am fortunate that my job allows me the opportunity to work with all of the local health officials around this state. I also work closely with the Maryland Department of Health. I'm here today in support of House Bill 609, not only because I believe Dr. Polsky and his colleagues working at the local health level deserve the protections, the minimum protections provided in this bill, whether there's a pandemic or not, but also because I believe this bill is one about public health. It's about protecting and preserving our public health, because that's what our local health officials do day in and day out. By and large, the work that our health officials do, we take for granted. We go to a restaurant, we eat, we don't worry whether the food safety laws are being enforced, because they are. But no matter whether we're in a pandemic or not, there are issues in public health that are going to, at least in segments of our communities, be controversial. Whether it relates to reproductive education in schools or to health equity, working towards health equity. Some folks in the community, whether it's individuals, community groups, or businesses, are going to create controversy. We want to know and put our health officials in a position where they're using their required education, experience, and knowledge of their community to make the decisions that are best for their community from a public health perspective. So removing the hesitation, concern, or fear that they may have of being terminated for no good reason, simply because they made a decision that they know is best for the public health of their community, is the least that we can do to protect these health officials who have done more for us in the last 2 years than I care to explain here. So if you care about the health officials and if you care about public health, you'll vote favorable on House Bill 609. Thank you.
Thank you for your work. We really appreciate you. Next, we have Mr. David Bishop.
Hello, Madam Chair, Madam Vice Chair, and members of the committee. My name is David Bishai. I'm a physician. I am the former health officer of Harford County, and I was terminated without cause on October 22nd of last year. The county has still not found a replacement for me and is being served by an acting health officer with no background in health or in science. So I speak in favor of the bill because it brings transparency, and that is going to improve the performance of both the health officers and of the local officials who give us oversight. Secondly, the bill does not take power away from local governing bodies. It adds accountability. Third, the abuse of health officers like myself that happens in one county poisons the well of talent for all the counties in the state. Annapolis has a duty to protect all Marylanders because counties with terminated health officers are having trouble recruiting. We've still not filled my opening, Montgomery County, still not filled. Other counties will have trouble with people wanting to do this job. So the current version actually requires confidentiality when a health officer is terminated. It requires closed meetings, and that needs to change. I learned firsthand that my county council was emboldened by the ability to act in secret, and they acted fecklessly. They put their own political posturing above their duty to the citizens. They wanted to advance their career, and if they had to be accountable for terminating a health officer, they would not have acted against me. My conduct was exemplary. We did no local mandates that deviated from the policies of the governor. I was the victim of a social media war conducted to further the careers of local politicians. It was not a policy question. It was the county council pursuing a feckless task for its own sake. And now you've lost my services, and other counties will go without high talent qualified services.
Thank you for your testimony today. We appreciate it. Next, we have Ms. Susan Delene Botkin.
Thank you, Madam Chairman and Madam Vice Chairman and committee members. I am Susan Delene Botkin, family nurse practitioner from Easton, Maryland, requesting a favorable position on HB 609. For the past 25 years, I have had a healthcare practice on the Eastern Shore of Maryland. My team and I have 2,000 patients from the 4 midshore counties. We work with folks from all economic strata: farmers, watermen, high-tech business people, police, teachers, nurses. In my spare time, I am president of the local school board. One thing my patients and constituents rely on is the need for truth. I have to be able to provide them with accurate information on health options within our region. I need to keep their vaccination statuses up to date. Let them know if there is a water or sewage problem. I have to be able to inform them of infections, bacterial and viral, that are in our area, and help them plan how to deal with STDs, tuberculosis, strep, influenza, HIV, AIDS, Vibrio, Mycobacterium marinum, opioid use and abuse, and COVID. I rely on our public health officer to provide me with accurate local and regional information. They help to provide equitable health care across the cultural divides. They ensure that the health gaps are filled in whether for vaccines for children, rabies, or masking appropriately. The county health officers are not political entities. They are professional medical specialists with advanced training in public health, and they stand between health chaos and order if they are allowed to do their nonpartisan job. And just as any healthcare professional, their removal must be predicated on reasonable grounds as outlined and with due process. Thank you. I ask you for a favorable vote on HB 609.
And thank you to your, for your service in an area that you're really needed. So we're
Thank
really
you.
grateful. Ms. Beth Resnick.
Yes, thank you, Madam Vice Chair and Madam Chair, members of the committee. My name is Beth Resnick. I'm a senior scientist in the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. The first decade of my career was spent working at the National Association of County and City Health Officials, NACCHO, to support and advance the capacity of our nation's nearly 3,000 local health departments. I'm honored to come before this committee today to ask you to give a favorable report on HB 609. The opinions expressed today are my own and do not necessarily reflect the views of the Johns Hopkins University. Public health officials are servants that work to protect and promote the health of all populations within their jurisdiction, including the responsibility to develop, champion, and enforce laws that affect health. Health officers, like directors of other county agencies, serve at the pleasure of elected officials. However, when it comes to Maryland's termination policies, state-employed health officers and county-employed division directors should be reassessed. As COVID has shown us all, health officers need considerations to allow them to reflect the best scientific and medical evidence to protect the health of all Marylanders. HB 609 aims to improve the current termination process with procedures to lessen the potential political pressure to influence decisions that directly impact the health and safety of Maryland residents. Health officers are responsible for the enforcement of state laws, as well as orders issued by the governor and health secretary. Health officers must take actions based on state and national guidelines and standards, including the CDC, NIH, state professional boards, as well as physician and nursing codes of ethics. This differentiates health officers from other appointees who serve at the pleasure of elected officials and can result in health officers being put in very difficult political situations when there is disagreement between state and local leaders. Thus, it is paramount that decisions directly affecting public health be based on science and evidence, not undue political pressure. The goal of HB 609 is to assure Marylanders that actions are being taken in the best interest of their health and safety. Thank you.
Thank you for your testimony today. We really appreciate it. Now we're opening it up for questions. I see Delegate Chisholm. Good afternoon, Delegate.
Thank you, Madam Chair. And
my pleasure.
The question is really for you. It's an interesting bill, and if we're trying to take political pressures off of the health officers and make it so that they can operate without any undue pressure, and I know it's not in the bill, but would you be open to maybe an amendment that says that previous political candidates or politicians could not be appointed to health secretaries or health officers?
I think that that's for anyone can bring any amendments to the committee. So if the bill is assigned to subcommittee, you most definitely can discuss it.
Thank you, Madam Chair.
My pleasure. Delegate Krebs.
Thank you, Madam Chair.
My
I
pleasure.
was just trying to find out, I know this situation happened a couple of times, and I think the gentleman from Harford County indicated, but how do you find the balance with transparency in this process and then personnel records, which must be left private and confidential as in other parts of the code? So how would you find that balance when you go to let someone go that you're not allowed to tell them why you dismiss them, or say publicly? How would you determine that in this bill?
I think that what the bill says is that once the health officer is given notice that they're being let go for the immorality, misconduct in office, insubordination, incompetency, or willful neglect of duty, the secretary has to provide notification in writing on the basis. So that notification goes to the employee, and the employee will be the one they will have, will have that information. It's not the public that will have it. The notification in the bill says that it will go to the health officer, not to the public.
Okay, because I think part of the concern, the publicity behind some of the other things with some of these dismissals was that the whole story couldn't be told. And I don't know. I'm just saying, how would you ever get that out when it's a personnel issue? But we can discuss that in subcommittee, because it could be something that we don't know. Thank you.
My pleasure. Thank you for the question. Delegate Kipke.
Thank you, Madam Chairman. I'm looking at the bill and I'm curious about two things. Currently, to remove a health secretary for a local jurisdiction, can the local body, the local authority remove them exclusively, or did they need to have the secretary in agreement? And then the second question is, where it says insubordination is one of the grounds for removing the health officer, who would they be? Who are they subordinate to? To whomever is best to answer the question. Thank you.
I think that if I may address the first one, it will be the secretary has to be in agreement when the local government is actually recommending removal. I would have Ms. Hoke address the second part of the question about the insubordination.
Is that currently the case? Does the secretary currently have to
yes.
with removal? Okay, thank you.
Yes, my pleasure. Thank you for the question.
Right, so that's not a change in the law. But as far as insubordination is concerned, I mean, I actually don't think that it has to be as kind of narrowed as who's your boss and you're insubordinate to that person. But health officers are in an interesting quasi capacity, right? They are actually state officials, and the Secretary of Health is technically their boss, and the governor is technically their boss. Yet they also have a relationship at being hired and having responsibilities toward the County Board of Health, as well in some jurisdictions that's separate from the County Council, but as well as the County Council or County Commissioners. And so I'd say, the concern that Dr. Polsky mentioned, that if they ignore state law or local law and aren't doing their job, that would qualify as insubordination. That's not following the direction of this body or of the local body as far as law is concerned. So I think they actually are responsive to both and subordinate, if you will, to both.
Okay, thank you.
Did that answer your question?
Yes, thank you very much. It's a delegate's question, and thank you for addressing it. Delegate Saab. Good afternoon.
Thank you, Madam Chairman.
My pleasure.
I guess the question under this bill, if the new administration comes in, can they replace them? Because those officers, they basically serve at the pleasure of the county executive or the leadership or the president commissioner or whatever, depending on the structure of the county. So when a new administration comes in, are they forced to keep them, or can they just hire somebody new? How would that work?
And I guess, Ms. Hope, would you like to take that? I was going to take it, but you go ahead.
Sure. I mean, under existing law, there are, a new administration, any administration can remove a health officer anytime for no reason whatsoever. If this bill were to pass, it is the case that if a new administration were to come in, whether that's a new Secretary of Health or it's the county governing body that technically has the role here, and so that's mostly the county council or the county commissioners, they could not terminate unless there are one of the spelled out reasons in this bill. I will tell you that historically, it's not the county executive, it's the county governing body, but historically, when we see changes in administration, we do not see changes in health officers because, again, they have been acting in the interest of public health and, frankly, apolitically. And so they're not one of those positions that we see turn over like that because they're really public health appointees and not political appointees.
Right. I mean, maybe in the past that was the case, but as we've seen during the pandemic, that those positions become very political. And this is what I fear, that it takes away the autonomy from the leadership to be able to appoint who they, technically align. So thank you for answering my question, though. I appreciate it.
My pleasure. Thank you, Delegate. I have Delegate Hill, followed by Delegate Lewis.
Thank you, Madam Chair, and thank you for this bill.
Pleasure.
And this will be up to you. It's either for you or Ms. Hoke. So my understanding is that even prior to the pandemic, in recent years, we have had issues with public health officers, unlike more traditionally what we've seen, being vetted in different ways, vetted more along political lines. And so the pandemic kind of put a cherry on that. So I guess the first part is, am I wrong about that? And maybe that's a public health officer answer. But I want you to have an opportunity to answer MACO's concerns, since you won't get an opportunity after they testify, as to, does this take away some ability of county leadership to decide who will act as their advocates, because it seems like the statement that has been made is that they really are working for the state and the governor as the advocates for the people, not as the advocates for the county leadership. So I just wanted an answer to that. And as I said, a correction if I'm wrong, that we've seen a politicization that preceded the pandemic. Thank you.
Ms. Hope, would you like to take it, or do you want me to take it?
Up to you. You want me to?
Okay, sure, go.
I say you have to talk all day. I'll go ahead. And I also want to, if there's time to kick it to Dr. Polsky, if he has experience about your first part of your question. But I am not going to disagree that this does remove some power from the local governing body and even the secretary to terminate a local health officer. That's what this bill is about at its core. But the whole goal of that is to soften the politicization of public health. And so we're not experiencing that. I've read MACO's letter, in opposition. I understand their opposition, and it's natural that any boss wants to be able to remove an employee for no reason. So they don't have to go through the more difficult process of articulating and defending that particular reason. So it's natural that MACO would be opposed to this. But I don't see, deep outrage in their letter that says this would undermine public health in our community or confidence in our public health. And since that's what I really think this bill is about, I think we accomplish it by providing the protection.
Thank you so much. You did it better than I would have done.
The first part of the question, Madam Chair, maybe.
Yes.
Dr. Bishai or Polsky.
So Delegate Hill, I will say from my personal experience that the process was not performed by elected officials, that there were members within the community who traditionally work on health-related issues, social service issues, who perform the interviews of the candidates. They in turn selected, and I don't know if they just chose one person or they narrowed it down. And then I had a second interview with the county commissioners as sort of a confirmation process. But the actual selection process, at least in my experience, was very apolitical. And I will say that when I was in private practice, where occasionally political issues interject their ways into offices, and certainly in my role here, I am always extraordinarily conscious that I am responsible for the health and well-being of every member of my county. It doesn't matter what their political affiliation is. And I think I can speak for all of my colleagues that we are very, very cognizant of the fact that that has no place in our decision-making process as we move through issues.
Thank you. Next, we have Delegate Robin Lewis, followed by Delegate Johnson, followed by Delegate Riley.
Thank you, Madam Chair. Thank you for this important bill, and to all of the panelists. I'm curious, and I don't know who's best poised to answer this question, but I'm curious about what the current law says about the duty to protect or the duty to avoid harm. It strikes me that the sort of capricious removal of a public health officer during a public health crisis or any other emergency, humanitarian or otherwise, constitutes a lack of an abandonment of the duty of responsibility to protect public health. It seems to me in settings where there is now no health officer, that puts the health of the public at risk. I'm wondering what the law says about that duty, if the bill addresses it, and if not, if we should think about it. Who might be best to answer that, Madam Chair? Perhaps
Ms.
yourself.
I guess as the lawyer in the group, that'll make me Delegate Lewis. Thank you for the question. And it's a tough one to answer more conceptually than directly. So with respect to who has the responsibility to protect and preserve the public health, surely in creating the system that you've created in state law of local health officers, they have duties and responsibilities to protect and preserve the public health that are well stated in the Health General article, as does the Secretary of Health. With respect to the county governing bodies, however, we don't see that direction, right? We can look in the provisions creating home rule powers, charter counties, and they have plenary public health power, but nothing hoists upon the county council or county commissioners a responsibility directly for the public health of the community, like it does for the secretary and for the public health officials. So I'm not sure how we would incorporate that into the bill. I think it's an amazing question, and I'd like to think through it. But what I hear from you is I think that there's at least the secretary having to also authorize the removal, agree to the removal of a health official, and the secretary having the responsibility to all of us of protecting and preserving public health has breached that responsibility when they've removed a good health officer for no reason and left a county without a health official. So I agree with you that that is a breach of that duty in the secretary, but I don't see that duty in the county commissioners as directly as I do for the secretary.
Thank you. Thank you, Madam Chair.
My pleasure. Delegate Johnson, followed by Delegate Riley.
Thank you, Madam Chairman. In my county, our county council is the Board of Health. So I wonder if Dr. Bashai would be willing to answer the question that Delegate Hill had asked to Dr. Polsky.
Well,
Dr. Bashai.
yes, the county council as Board of Health is responsible for health. And what happened to me was they never talked to me about what I was doing wrong, and they still haven't said anything to me. It would be legitimate if we were having a policy discussion that I could have been insubordinate about, but they didn't do that. They simply acted in a political manner, listening to a minority of vocal anti-science protesters who were instigated by people who were gaining political hay from saying, you know, we hate masks. But as a Board of Health, they weren't functioning that way. I was on the phone with county council on substantive matters, and I never heard a suggestion that I alter my conduct in any way. And now that they've terminated me, they have still not had to say why they did, which I believe causes citizens to wonder. So I've been vocal about why I think they did it, but they have never had to say why. So I would have valued opening the shroud of the personnel matter, and I have the prerogative to under this proposed legislation. I don't right now. I cannot ask them to explain why they terminated me, which does reflect poorly on me, and it's not fair. I was an exemplary health officer, and now my reputation's been damaged because they do not have to say why they terminated me.
Thank you, Doctor. And thank you, Madam Chair.
My pleasure. Delegate Riley, good afternoon.
Good afternoon. Thank you, Madam Chair.
My pleasure.
Yeah. Yes. So a couple questions just to understand. Okay. So currently, Dr. Bashai, you are an appointed position. You are an appointed position, and I'm gathering that was appointed by the county executive or the county council or both. I'm not sure.
By the county council.
Okay.
County council serving as Board of Health.
Okay. So in this situation, if we would pass this bill, then you would be, I guess, different than any other position, appointed position in local government. Do you see a problem with that, or is that, would you consider that fair? Because no other appointed person under a government body would have this opportunity to have other reasons of why they could be terminated, but yet your position would, because under this bill, you're still appointed?
Well, I believe that this is a special position. It is a position that requires scientific neutrality, and we're not asking for more than, but they can still terminate me for not listening. Insubordination equals not doing what they say. Tell me I was insubordinate and then terminate me, and we can be public about it. It's not that special. And I still have a lot of power, but they didn't even use their power. They simply follow politics, and that's wrong. Now, that is stopping the scientific conduct that the county and the residents needed, and that's percolating across the state now.
Yeah, I can't assume why they fired you. I don't know the reasons, but I wouldn't, assume that they fired you for political reasons either, since I don't know. So just to clear that up. But thank you for your answers. I appreciate it.
Thank you, Delegate Riley. Any other questions? Seeing none, I have one question for Ms. Hoke. Just to follow up on the last question by Delegate Riley. Tell us, the question of there are no other appointed person that has these protections. Why would it be important with this position?
So interestingly, there is a very similar situation from which this language is actually borrowed. So the language in this bill is quite similar to the language with respect to the reasons for which a local school superintendent may be terminated. And it's a very similar situation with local superintendents, where there's the local school board, the county school board, the local superintendent, but also a quasi relationship with the superintendent of Maryland state schools and a role for the state school board. And these provisions, setting this speed bump for termination, having some grounds for termination, are actually borrowed from those, it's word for word from that statute. So it is, unique in that it borrows from that particular provision. And I think likewise, this is this is a position for which there should be more than no reason for a termination, just like there is in the school superintendent situation. And that law has been on the books for a really long time. I actually traced it back at least a couple of decades at this point, and it has worked effectively for the school systems, for the locals, as well as for the state, to make sure that there is continuity in the position and that terminations are based on cause and not, a whim or because of a, kind of public controversy in a part of the community.
Thank you. Any other questions? Seeing none, this concludes the bill hearing on House Bill 609. I want to thank everyone for coming and thank you for your service to the state of Maryland. We appreciate you. Colleagues, we're going to take a break because I know some of you had government operations and didn't get to eat and came straight to hearings. So it is 3:28. What if we came back at 3:50? Okay, you can get something to eat, and then we're going to deal with House Bill 761, 378, 370, and 517. We have 4 more bills to go. So I will see you back at 3:50. Thank you so much.
So our mic is open when they open it.
Okay, it's 3:50. So let's get started. And I want to thank the witnesses that are here for being patient with us. What happens is that we go all day without food. And there were people that were in, we got off the floor, went to subcommittee, and the government operations subcommittee members came straight to hearing without eating. And we just need to stay healthy, right? This is the health committee after all. So thanks for being patient. Is Delegate Krebs back?
I'm back. Are we live?
Yes, we're live. Thank you, Delegate Krebs, for your patience. So the next bill is House Bill 761, Delegate Krebs, titled County Boards of Health and Baltimore City Health Department Procedures and Appeal Process. Good afternoon, Delegate Krebs.
Thank you, Madam Chair. This sort of follows along with the discussion we were having before the break regarding health officers, and I feel their pain on some issues. So I always ask, what's the problem we're trying to solve? And I think during the pandemic, a lot of issues came up that we really were not expecting. And it increased the burdens and responsibilities that were placed on the shoulders of their inspectors and all of their staff. And they have been on the front lines of making a lot of these decisions. And most of them are, very dedicated public servants in a tough spot. But sometimes the public gets frustrated that too much is being done or too little is being done. But sometimes there are instances where their decisions seem to be, sometimes they appear arbitrary, sometimes inconsistent and unreasonable. And these frustrations came about long before COVID. And I don't want this to be about COVID because it is not, but they were certainly exacerbated during the pandemic. So what am I talking about? Well, first of all, this bill basically says there needs to be clear and understandable requirements regarding inspections, citations, cease orders, and local appeals process for local health department decisions. And why do we need this? I had the library, the Department of Legislative Services library, do some research for me. And currently in COMAR, there are no regulations regarding the oversight of local health officers or their staff. And again, every time I say local health, it is their staff, the inspectors that go out. And the board of the local boards of health, they're supposed to have oversight, but they really, in the past, I don't think have exercised that oversight, or the secretary, which is very far removed from our citizens, that sometimes our businesses and our citizens that are being impacted by this. So the authority of the Secretary of Health over local health officers is very vaguely described in Health General 3306. And I basically put that in my testimony, exactly what it says, but it's a very vague authority to the health officer. I think this committee, after reading it, will realize that may need to be strengthened, or we need to somehow strengthen this process or this oversight. There's nothing in law that gives the Secretary of Health any control over local health officers, and there is no appeals process with the local health officer required in COMAR. The only remedy, and they talk about remedy, I think the health officers, when they oppose this, they'll say, oh, there's a remedy. The only remedy is the Office of Administrative Hearings. Now, when you have a small complaint, you shouldn't have to go all the way to the Office of Administrative Hearings. There should be a local process, even within the Department of Health, to sort of work on some of these issues. And according to Mako's testimony, they said some of the counties already have a process in place, and that may be true, and that's wonderful. But all counties need to have a process in place for all of these kinds of, it needs to be consistent, it needs to be codified in policy. And the person that is getting the order to do something, and it can range on many different things, should know what it is they're violating. They should clearly know, here's the rule that you're violating, and this is why you can't do it anymore. And often the inspector goes out with no explanation of applied law and just basically says, here, you must do something. And we don't, and then the person, they call us, they call me, they call someone else, and that's just not a way to operate. I really can't think of any other place in law that we don't have a process in place, whether it's zoning or law enforcement. There's always a process clearly stated. So right now there are blurred lines of responsibility and unclear roles of this local health officer and the respective boards of health. So as a result, the public is often confused and there's little accountability. Sometimes there's arbitrary applications of environmental law and food safety regulations. And we know this, we've heard this in our committee. between restaurants and schools and excluded organizations such as churches, the cottage food industry, farms, charitable organizations, and farming-related operations, private events. So sometimes there's no clear law cited what they violated, and no real process to get to the bottom of it. So what does this bill do? Basically, it requires that each county and each county board, along with their local health board, require that any citation or order to cease operations must reference a specific law or policy that was violated and a summary of the options for appealing the citation or order, including the appeals process. And this makes it only fair. And again, it's done locally. Each local jurisdiction can figure that out. And if they already have a process in place, then they can share it with the other counties that don't have quite a clear process in place. So I believe this would bring back some accountability. Plus, it would also give some protection to our local health officers at a very frustrating time. And they would partner with their local boards of health to make sure that there's a process in place that is done consistently, ensure accountability and reasonableness as our public health laws apply to our citizens and their businesses. So with that, I ask a favorable vote on House Bill 761.
Thank you, Delegate Krebs. We have next Johnny Mutz.
Madam Chair, I do believe there's Jennifer Dewick is going to go next, and then I think there are three other gentlemen that were here before we broke. But Jennifer Dewick, is she on?
Yes, I am.
Why don't you go ahead, Jennifer?
Okay, and just bear with me because I thought I had 3 minutes and I prepared for 3, so I will go as fast as I can. Firstly, I just want to say thank you so much for giving me the opportunity to be here. It's an honor. My name is Jennifer Dewick. I am the wife of a disabled veteran, a homeschool mom, and a small business owner in Maryland. With a business under 2 years old, I have just recently walked through all the processes, the procedures, and the red tape such an undertaking requires. Each step along the way has provided its own challenges, but we have always been given guidance, advice, and in the end, education about our rights and the law, which provides us with the guidelines on which we are required to comply with in order to run our business. While our experiences with the health department have always been pleasant, we have experienced overreach of this department, which led me to be here today. Over the summer, I was forced to reach out for help to Delegate Krebs as we navigated these challenges. The health department had required our farm business to provide the public with portable restrooms. When an angry neighbor called in a complaint about the mere existence of them on our property, a health officer visited to follow up on that complaint as they were required to do by law. Throughout the visit, the requests and the rules for our portable restrooms changed multiple times, despite the officer admitting that we had not only complied, but that we were still in compliance even upon her visit. First, she requested that we remove the restrooms each week as our business hours are Friday through Sunday. Then, when questioned, that requirement changed to the health officer requesting we move them so they could be hidden from sight and placed back during our working hours. When I asked if this was written law regarding these requests, the health officer told me she didn't know health law regarding this and would have to get back to me. To this day, after using Google as a legal guide, the health department is not allowing my farm business to have portable restroom on site or serve food to our customers without meeting Google's guidelines, which is an attempt to enforce laws that simply do not exist, infringe on our rights as compliant Maryland property owners, and are completely arbitrary. This bill will put in place a process which will allow Maryland business owners to appeal decisions of the health department, yes. But more importantly, this bill will provide guidance to both the health department and the opposing party, allowing them to work together to solve issues as they arise. Without knowing the laws, regulations, and rules that actually exist and are enforceable, the health department is unable to use their power without prejudice. And Maryland residents will continue to lack an understanding of the actual laws, leading, I believe, to more frustrations and non-compliance. If the health department is allowed to continue without the checks and balances that are provided in nearly every other government entity, overreach and unclear regulations will continue to confuse and frustrate small business owners and drive small businesses like mine from Maryland. I share today simply because this is not just my story. There are many other stories like mine. The other businesses did not know where to turn.
Can I ask, wait, I allow you to go a minute more, but can you please wrap it up? Find a place to wrap it up.
I have like 3 sentences left. I promise.
Okay.
The other businesses did not know where to turn for guidance and a clear understanding. They did not have a clear understanding for their rights in the law. This bill, if passed, will give that guidance, will help protect the integrity of the Maryland health codes and ensure compliance. I appreciate your time in hearing me, and thanks for letting me go over.
It's okay. I understand. You didn't know. So we appreciate your testimony. Delegate Krebs, who would you like to go next?
Mr. Fritz and Mr. Stoffel, and there's another person, I believe.
Okay, Mr.
they're
Fritz,
still
will
on.
you go next, please? Good afternoon, Mr. Fritz. Are you here? How about Mr. Stolfels?
I think Mr. Fritz is trying to get off of mute.
Okay.
I see him down there.
Mr. Fritz, can you hear us?
Yes, can you hear us now?
Yes, I can. Will
I'm
you be
sorry.
so kind? It's okay. Don't worry. It happens. Will you be so kind and get started?
Yes, we're going
Thank
to have
you.
Mr. Stolfus speak for both of us. Go ahead, Eli.
Hi, my name is Eli Stolfus, owner of Country Cheese and Salads, and we're do business in Amish Market in Easton, Maryland. And a couple days ago, we submitted a testimony, a letter to the Talbot County Health Department. And of course, today now I'm oral testimony. I'm not really, this is something I don't do as, Anyway, we have worked hard for the 14 years to provide high quality, fresh, healthy food to our customers. And we truly want to comply with all regulations and stay with the safety and the regulations. I'm in favor of this bill 761 for the following reasons. First, it's hard to find the regulations. We don't have access to online information. I'm told we have to pay to get the regulations. It seems to me that we should be able to get a copy of this regulation that you pass without having to pay for it. Second, it's hard to determine what is recommended by the health department required, for example, logbooks. Explain. Also inspect reports do not correlate to violations such as cooling methods with the actual regulations that apply. It seems to me that regulations should be clearly written so that business owners and their employees can understand them, apply the rules to our situation, quickly review a violation and specific regulations that apply, and easy to distinguish between recommendations and requirements by the health department. Third, it is hard for a small business to stay up to date and keep our employees knowledgeable about regulations. I believe education is one of the responsibilities of health department, but we haven't received any training in the last couple of years. Fourth, inspections can be very disruptive during our peak hours. For example, 3 weeks ago, we had an inspector in our facility, 6 hours throughout the day. We had long lines. So the long period of questioning and stopping my employees while doing their work. It seems to me that there should be a partnership with the health department where routine inspections are conducted outside our busiest hours, where there is time for us to learn from the inspectors and the inspectors can ensure food safety. Thank you.
My pleasure. And since you spoke for both for two people, I decided it was okay to go over. Thank you so much. We appreciate you. And thank you for your business. I think we have Nick Roberts. Mr. Roberts, are you here? Mr. Roberts? Is he in here, Susanna? I was told he was next.
I do not, and he might have left because of the break. I don't know. I don't see it.
He is here. He should be speaking for Mill Creek Farms.
Yeah, I actually see him there. Nick
Okay, I'm sorry.
Roberts, he's just muted. Can you unmute him, please?
Yes, I'll ask him to unmute right now.
Thank you so much. Mr. Roberts, can you hear us?
Yes.
Will you be so kind and provide us your testimony? You have 2 minutes and welcome.
Okay. The reason that I'm speaking today is I'm a little confused on food service license. It seems as if the county that I'm in has combined food service with prepackaged items such as cheese, bacon, butter, eggs, etc. To me, food service is deli, cooking hamburgers, serving food, even if it's a grocery store or whatever. That's food service. But as far as these other items, I don't touch them. I take them out of a box. I put them in a refrigerated case. Last year, I've been there 40 years. For 39 years, I was selling all these items. A new individual came in and said that I can no longer sell them because I don't have a food service license. And they've also included ice cream, such as Dixie cups, popsicles, ice cream sandwiches. Every little every little store, like mom and pop store, hardware stores, everybody sells ice cream. I don't dip ice cream. I don't prepare any food. All I do is take the stuff out of a box and put it in a refrigerated case. What I'm looking for is some relief on this, or separation of this food service license, where these items shouldn't be included: cheese, bacon, butter, so on, etc. And that's what the issue is here now with me. So I'm hoping maybe you can help me on this somewhere down the line. They also outlawed eggs, which these items are big. I have a country store, a little general store, been there for 40 years. I've never had a problem with the health department until they came in and told me I got to remove all these foods. They're calling it potentially hazardous. Okay, thank you.
Thank you so much. I'll have to come and visit your store. Thank you so much.
Okay.
We have actually, there are no other witnesses for Delegate Krebs' bill that are favorable. So we're going to ask the questions now. There's an unfavorable panel afterwards. So are there any questions for Delegate Krebs and for her panel? I see Delegate Shalega. Good afternoon.
Good afternoon. Thank you so much. And this is
pleasure.
for Jennifer Dewick. Are you still here?
I am.
There you are. Sorry. It's hard on the screen to find people. So it sounds like you are having trouble with due process. So this complaint was made, the health department came, you don't know where to go to get this remedied. Is that what I'm hearing?
Correct. So, I mean, essentially, we're a flower and lavender farm. So we're approaching our new season, and I really have no guidance other than these rules that they're enforcing on us that aren't really rules. And there's nowhere for me to go other than to call up Delegate Krebs, who has been so helpful to me.
So, right. And so the person that is making the rules is the unelected health officer. Is that right? The health officer comes out and then he or she doesn't even have a copy of the rules to give you and can't give you clear direction?
Correct. I mean, when I asked just simply, I was shocked that she was there. So I've never been through this sort of, circumstance before, but I was smart enough to just say, hey, do you have something you can give me? She wouldn't even give me the complaint. I had to make a request to get the complaint. And then I had to make a request to get the proof that we were compliant, which was helpful for us because that same neighbor took us to court and we had due process, which thankfully stood behind our business. And so that due process is just important for the health department, simply for people like me and other, civilians in Maryland.
So the only way that you could get remedy was to actually go to court.
So that court issue was actually just to shut our farm down. Our neighbors did not even want our farm in existence. So that the health issue was sort of a separate issue, but I kind of wanted to bring that up just as an example of there was a process in place to protect our farm, if that makes sense. Is that?
Yes.
Yeah.
That's great. Thank you. I had a swimming pool business with a similar problem with the health department in a county where the health officer did the same thing. He had nowhere to go for due process. I actually had to find some scientific evidence, on his behalf, but there was nowhere to go because the health officer made the rule and enforced the rule and changed the rule. And there was no one else besides your elected official that could intervene. Thanks for being here, Jen.
Yes, thank you so much.
Okay, thank you. Delegate Riley.
Thank you, Madam Chair. I guess my question would be probably more so for Delegate Krebs, the sponsor of the bill. So basically, is this bill just asking for, I think it's asking for two things, but one thing that's not prevalent in the title would be you're asking for accountability from our local health departments?
Yes, it's basically asking them to make sure they have a process. And again, some may not, but I know our county does it and a number of other counties don't. To have a process where you clearly have to tell the person what their violation is. And in some things like restaurant inspections, I think there's a checklist. But for some of these other things, when they go out to the nonprofits or go out to a farm, they just tell them stuff. They don't even write it down. They don't tell them where it is in the code. And very often it's not in there. And it's not the health officer, it's their inspectors. And then so it would just make them have a citation that tells them where it says it in the code, what are they violating, educate them. And then, as in the sake of the gentleman who's been doing his business for 40 years, that they have a new interpretation because a new person came out, it would allow this process that they put in place. It might be appealed to the health officer. It could be they're going to put the process in place that would work its way up. But at the end, the Board of Health, which is the local officials in that county, would make sure that kind of process is in place, just so they get answers. Right now, it depends. It is very arbitrary who comes out. And sometimes the health officers the health inspectors are not educated themselves. They almost need. And again, I'm not saying it's happening everywhere, but I think it's broad enough that there's just no clear process in place. And I've left it to the local counties, because I believe in local control, to make sure those processes are in place. Montgomery might look different from Somerset.
Thank you, Delegate Krebs. I just found it interesting during your testimony where you said they go out and they give them a citation or whatever and, gig them, but yet they don't give them a reason why. And it's not written anywhere. So very interesting. Thank you so much for the bill.
Delegate Kaiser.
Thank you, Madam Chair. Delegate Krebs, thank you. I think this bill is spot on in our need for transparency. Have you considered working with the sponsor of the prior bill about the health director getting fired without reason? So we have openness and transparency on all parts of the process?
No, but I just saw it when we had the hearing, and it made me think there are some similarities. Some of the problems are occurring because there isn't a process and people feel aggrieved. And I think there is a lot of benefits of both of these. And I think it would solve a lot of problems if people knew where the rules were coming from and who was we shouldn't have a dictate. We shouldn't have one person being able to say, do this or do that. I think there could be a marriage of similarities and everybody could be a winner. So,
win-win. I love it. Thank you.
And you came from the education subcommittee. And I said, even in education, there's an appeal process for a student that gets, suspended from school. There's nowhere else that I know of in law that we don't have clear appeal processes when you're taking someone's rights away or their property. Thank you.
Thank you. I have Chairman Pendergrass, followed by Delegate Hill, and then Saab and Chisholm.
This is for Delegate Krebs. Oh, yeah, I did open it up. Thank you. Thank you, Madam Chair. This is for Delegate Krebs. The concept of this is good. There should be information given to people when there's a problem. The problem is that this is kind of a heavy-handed way to deal with it. And I'm wondering if you've talked to the local government, if you've tried to work with the council person or commissioner from that area. It feels like a local government issue to me. It doesn't feel like something that we need to be mandating. Can you tell me?
Well, I believe you're right. And that's why I've made it that at least the local governments have to make sure there is a process in place. And clearly the violation has to be stated. And I think that should be true everywhere. But I did leave it to local government. I've talked to Mako, I've talked to Kevin Canale, and we're going to try to work something out. And I think some counties do it better than others. But our commissioners and our Board of Health, and I think in these other, the other folks aren't from my county that testified, but I think some of the local boards of health don't understand that they really have any power. I think during COVID, they realized that, hey, we're the Board of Health, but the boards of health really aren't, it's not articulated anywhere in state law what their responsibilities are. And I think this would just give them the ability to say, yes, it is my responsibility to make sure that the local health department has this process in place. So I'm trying to leave it up to local government to ensure the process is there to the best of my ability without being dictating the details of it. That's my attempt.
Any other questions, Chairman? Okay, we have next Delegate Hill, followed by Delegate Saab, followed by Delegate Chisholm. Delegate Hill, will you be so kind and ask your
Sure.
question?
Sure. Thank you, Delegate Krebs. So I think, the board of the public health officers are going to come after you, right? And I'm sure in the hearing today, you got to read their testimony. And I've certainly had the experience in one of the jurisdictions where I serve of having someone open up a pizzeria to be told, you can't open yet until you get a fry sink, only to be told after investing the money by the next health officer, oh, you don't do any frying food, so you don't need a fry sink, right? So, and I think sometimes folks go out and say things and they go back and find out it's not correct, but this doesn't really get to that. And what the health officers are saying is that most of the things you're asking for are already either how they practice or what's required. And the one difference is this issue that you have in here about to whom do you appeal and who has the final say. And they're questioning why you would give the final say on a health issue, a public health issue, to the local non-health body, political body, as opposed to, say, the secretary or something. So I'd like you to address, why did you come down saying that the final decision on the appeal should not rest with someone with a health first interest? Well, first of all, they still have to follow the laws that we have made and the laws that are in COMAR. So it's basically, how are they being applied? So the issue you have with the fry sink, when that inspector went out and told them they needed a fry sink, they shouldn't have just told them that. They should have told them, here's where it says it in COMAR that you must have a fry sink. And I had a similar situation in our crepe place where they told them they had to have some special equipment and it wasn't written anywhere. So in the first place, I think a lot of these things would not happen because there is accountability right up front for them to show them in the law, where does it say you have to have this? And then I see very few things going to the Board of Health. They would have a process locally, like with the health officer, with the supervisor first, and then they'd have to come together and discuss, hey, why do I need to have this? The gentleman that spoke about the different products that he can't sell. Right now, he has no remedy. There's no remedy to even go to the boss or tell him, what do I do next? This person told me I can't do these things. What do I do now? And I don't think it's just the Board of Health, the local officials would make sure that process is in place, and they still have to follow the rules. They still have to follow the laws that are in COMAR and are written. So it's not that they need public health. I mean, judges don't necessarily, the law of administrative hearings doesn't have any kind of public health education either, and that's where they have to go now. So some of it's just common sense. Is there a rule or is there not a rule, and does it apply? All right, thank you.
I have next Delegate Saab, followed by Delegate Chisholm.
Thank you, Madam Chairman. My question actually is to one of your, Jen, I'm sorry, I don't see you. One of your.
Jennifer Dewick?
Jennifer.
Yes, thank you. There you are. All right, okay. So obviously, I'm not sure if you had the opportunity to look at the opposition letter from the Maryland Association of County Health Officers. And in it, it says, what they're claiming is most of the stipulation in House Bill 761 already exists, and local health departments staff cite specific law or policy in any enforcement action and provide the business owner with instruction for the appeal process available to any action taken. So I guess in your case, it didn't work. And while I was listening to the testimony, I went to my own Anne Arundel County Health website, and there's nothing that I can search in the search menu for appeal or anything like that. So I know you won't have the opportunity to come back if they are coming to testify. So can you explain to us, did the process that they claim is in place worked, or it didn't in your case?
So in my case specifically, the health officer came here based off of that complaint from a neighbor. She arrived, she immediately told me, hey, you had a complaint, you need to remove it. And I pulled up my emails with the other officer that had given me my rules. And I said, well, I'm doing this because y'all told me I had to provide this for the public. And she kind of backtracked a little bit. And that was pretty much the end of the process. I mean, the process from there was simply me having to track down this complaint and then having to track down the fact that that she said we were compliant. And that's where the process ended. I've never had any communication from them since then, other than them telling me that I needed to follow these rules. They want me to have a pump and haul contract. So the director at that time had Googled best practices. So this is not in the law. There's nothing in the law that states that I have to have a pump and haul contract. In fact, if they knew anything about portable restrooms, they would know that that's a normal part of most portable restrooms being delivered somewhere. There's a pump and haul contract. That's a normal practice, but it's not in the law that it has to be required in order for them to allow me to have it or to allow me to have food. In Carroll County, where I am, in order for you to serve food to the public, you have to provide a restroom. And so I was doing that, and they're telling me until I provide them with basically the things that they want that technically aren't really law, they will not provide me with any further approvals, even though I'm in compliance.
Thank you. So in other words, no specific laws were cited when they gave you the citation.
Correct.
Thank you.
Yes.
Delegate Chisholm.
Thank you, Madam Chair.
My
And
pleasure.
thank you, Delegate Krebs, for bringing this. It's a passion of mine as well. One of the things I've always said in business is yeses are fine, nos are fine. I don't knows will put you in the grave. And I think this is what this bill speaks to. I didn't deal with any business owners or citizens that were openly defiant against any of these health officers or any of these inspectors. It was just mass confusion. And I know it was a special time, but just like the last speaker, they just need to be told exactly what they're in violation of or what requirements do they need to meet. And so my question really is for Delegate Krebs, because I know that we have different experiences depending on the county. I fielded hundreds of calls. So Delegate Krebs, how many calls did you field from either small businesses or just everyday citizens that were confused and frustrated with the whole system? And lastly, what was their only recourse? In my experience, it was a $10,000 to $15,000 lawsuit, which most people don't have and businesses can't afford. So I'm just curious on your input on that.
Well, on my end, I've been, this is my 20th year, and I will tell you, dealing with my local health inspectors has been one of the most challenging things that I've ever had to do, and I have really no say over it. And as a result of that, this committee knows a number of years ago that we actually put together a work group that I served on for 1 year that had to do with temporary food permits, because there was such stringency about having special events. And there was such dichotomy between counties of what they allowed you to do. And we re-ramped all the, Cliff Mitchell and Larry Polsky, who was a health officer. We served on this committee for a year. And we all also know that the cottage food laws that we have brought out because of this is a result of some of these loosening of restrictions. And believe me, you talk about politicization. Our health officers didn't really want us to do the cottage food bills, but we as elected officials said, our people want this. And we have pushed the cottage food industry. It's a very successful industry. So sometimes there's a healthy push and pull between what the health officers think and what we might think and what our citizens want. But I've been dealing with this for many years, and I only brought a few people here today because we're only supposed to have, a few people, but I've been dealing with this for a long time. And part of it is just not having a clear process in place and using risk to determine what we should do with some of these things. I mean, this guy's been selling his products for 40 years, and all of a sudden somebody comes in and says, you can't sell cheese anymore, or can't sell ice cream. Where is it coming from and what is the risk? And maybe we need to change the rules. We did that in the temporary food. When we had that work group a few years ago, we changed the temporary food permit rules because they were out of date and they really didn't make sense. So sometimes it takes some work to get these things fixed, but it's only right for our citizens to, especially this applies to our churches, our fire departments, our nonprofits, like I said, our cottage food industry. We've had problems with those types of people. And they do these things very infrequently. It's not like a restaurant that gets inspected all the time. So it seems to be people that are more, Miss Dewick is a farm. She's a lavender and tulip farm. She sells cottage food. That's what she sells. And they wanted her to have a porta pot because she sells a stand of cottage food. So she had to have the porta pot. Then they told her she couldn't put it where she wanted it. So anyway, I've been dealing with this for a long time. And everybody calls me because they know I try to follow up with it and try to find some balance in these things. But I'd like to memorialize it more in some kind of process so it's not such a disturbance for our citizens.
Thank you, Delegate. Thank you, Madam Chair.
My pleasure, Delegate Chisholm. We have Delegate Johnson, followed by Delegate Robin Lewis next.
Thank you, Madam Chairman, and
My
thank you,
pleasure.
Delegate Krebs, because I really like this bill. Having been in economic development in my county and also a business owner that was not only a pharmacy, but also a coffee bar in the front dealing with food, I have seen inconsistencies and I've seen inexperience. And so even though I do feel it's a local issue, because so many of our counties have different processes and different boards of health and a different setup, do you feel that we need to address this on a state level to make it consistent across the state for all of our counties, all of our citizens? And do you think we need to add an element of training for the health officers in your bill?
No, you got great points. And what I'm hopeful, I mean, our counties are different. Montgomery County has way more resources than a Somerset County. I'm hopeful that our health group through MACO will get together, our health officers will get together, share best practices, and put together a process that works for everybody, or talk about what they're already doing. I just would like it to be intrinsically the problem solved from them. Here's what we're trying to solve. You guys go back and this is what we want you to do. If we do top down, it's going to be resistant, and counties are all different sizes. And again, I'm hoping that the health officers take this on themselves, and I think they could, and put the process in place that we're looking for. And that's my, and it would be hopefully some consistency based on that, but different counties might handle it differently. I think handling these little things at the most local level with the health department. I mean, I see the original appeals going to the health department first, not going to some administrative law judge, but Ms. Dewick would be able to say, hey, I want to appeal this to your boss. I want to appeal this to the health, but right now there's nothing, they don't even know who to call. So that's the way I envision it, but it's not up to me. I'm hoping that the counties get together and find a way to comply.
Thank you. Thank you, Madam Chair.
Delegate Robin Lewis.
Thank you, Madam Chair. And thank you, Delegate Krebs, for your work. I know how committed you are to helping small businesses, and especially small food businesses, be successful in our state. Couple things. It strikes me that at the core of what you're proposing is a grievance process for small business owners who are concerned about decisions made by their local health departments regarding food protection. And we do have grievance processes set up for consumers. If you have a problem with your health insurance, there's a clear grievance process. You can call your insurance carrier or the HEAU. We're all familiar with that. But it sounds like what's missing from your perspective is a mechanism for small business owners to request an appeal or file a grievance of some kind on a decision. And that makes sense to me. That's a very, consumer-centered point of view. At the same time, it sounds like what you're proposing is broader dissemination and easier access to information about state regulations. And while I was listening to the other witnesses and questions, I went to the Maryland Department of Health office, and I did a Google search with Dr. Google and looked for Maryland food laws, and I got the Maryland Department of Health Office of Food Protection, which is a pretty clean and visually sort of accessible looking website. You can click through to find regulations about inspection and processing of and licensing for food processing. There is a click through for regulations about milk and dairy. But of course, you click through and it's not really very clear where to go. So I can see your point about just making it easier for people to find. And lastly, if I may, Madam Chair, I'd like to ask the bill sponsor if she's familiar with the mechanisms we have in place in Baltimore City
which is the only city in the state and has the highest per capita concentration of restaurants and the best, greatest multi-starred restaurants in the state. Food safety is a huge issue. And I wondered if you've looked at the tools Baltimore City has available. For example, you can go online and pull up an inspection for a restaurant, and it shows you exactly what the health inspector looked at, what codes or requirements were evaluated, what remedies are required. It's all online, and that seems like a great system to me. I wondered if you looked at that as a possible model for how other local departments might respond to the small business owners' needs.
So thank you for that. And I will tell you, I did talk to your former health officer who now works for Mako. I forgot his name. Had a long conversation with him in the fall when I was discussing this, and he explained to me all the things that were being done in Baltimore City. And I know there are clear inspection reports for restaurants. And I think Delegate Kaiser brought up or someone else, Delegate Hill brought up an issue about a new restaurant starting up. But I think the inspection process for restaurants is somewhat clear. You get a check mark and here's what you've done right or wrong. It's these other ancillary one-time, real small business, family farm, they don't have these check marks. They don't have an inspection form, and they're not clearly told what their violation is. You just looked. If someone comes out and tells me I can't do something, you shouldn't have to go search through the code and say, what am I violating? They should be telling you what you're violating. And that's step one, is telling them what their violation is based on what you just looked at. And I think Baltimore, and that's what I'm saying, some cities, some jurisdictions may already have some of this in place that could share with the other jurisdictions that are not as sophisticated. Somehow my internet's kicking off. I'm in my office.
Okay. Are there any other questions for this bill? And I don't see any. Delegate Krebs, I would agree with Delegate Kaiser that you and I have a lot in common with the bill that I put forward before, because it's about due process. It's about notice, and there's a need to be consistent, right? So I think that what I like, if I may give you some instructions, is will you be so kind and set up a meeting with Mako and with Micho, and can you work with my team so that I may be part of those meetings so you and I can have a conversation with them, okay? Because I also reviewed the file and I could not find an appeal process at all. So that would be wonderful. I actually, there are two other people I'm favorable, and that is Mr. Kevin Kennelly. Will you be so kind and get started?
Thank you very much, Madam Chair and members.
My pleasure.
Of the committee. Kevin Kennelly here on behalf of the Maryland Association of Counties. We're opposed to this bill. But the first thing I want to say is we really appreciate the conversations with Delegate Krebs. I certainly understand the intent of the bill, and listening to the sponsor panel certainly can empathize with a lot of the things that I was hearing. I think that number one, everyone should absolutely know, why they've been violated for something. And number two, there absolutely should be recourse, and the people should know what the recourse is. So we agree on those fronts. Really, the issue we have with the bill is at the back end. It sets up a new process that we view as pretty prescriptive. As you've already heard and talked about extensively, counties are different in the way they handle these matters, but certainly we can agree that we can probably do better here. So Delegate Krebs and I have been talking about this. We would love to have the meeting. Delegate Pena-Melnick, I think you just talked about that too. Happy to get the right people around the table to take a look at this and try to make the process better for everyone. Because again, I really do empathize with a lot of what I heard. And again, people should absolutely know why they've been violated, and they should have recourse, and they should know what that is. So I think we can get to a suitable place here and make this process better. And we're happy to continue to have that dialogue and get the right folks at the table to take that on. So with that, happy to continue working with the delegate, with the committee, and with anybody else that we need to bring to the table to solve this issue.
Thank you, Mr. Kennelly. I actually allowed the witnesses to go past the time and even the questions more time, because I really wanted to understand the issue. Sometimes it's hard to get it right.
Absolutely.
I think that it's really clear here that we need some type of appeal process. And I think, like you said, notice is important, right? Knowing what it is you did wrong and being able to have due process. So if you can make sure to be available for that meeting, but then start thinking about what can be, not so broadly like it is in the bill, but what can be a good process, appeal process, and notification process that perhaps we can start discussing, okay?
Absolutely. Thank you so much.
My pleasure. Are there any questions for Mr. Kennelly? Well, it's hard to see with the timer 1 minute. Thank you. I don't see any. I have next Mr. Brooke Thornton.
Yes, thank you. Good afternoon. My name is Brooke Thornton.
Oh, I apologize.
That I'm a miss. That's okay.
Yes, I apologize to you. Good afternoon.
My name is Brooke Thornton. I'm an attorney working at the University of Maryland, Carey School of Law. I'm here in my individual capacity, and I'm opposed to this bill. This is really purely for legal reasons, and I just want to lead with, I'm happy to offer any other support outside of here as necessary. But first, I just want to note that each time that a citation or a final decision or an actual order is issued, there is some type of due process, because if there wasn't, it would be a violation of our state constitution and our U.S. Constitution. And the second point I want to make, almost, most importantly, is that this bill doesn't actually accomplish the accountability or the oversight that it seeks to because of a conflation of the legal terms as they're described in this bill. So first, the reference to Baltimore City. Any comparison to the Baltimore City Health Department and a Board of Health is not accurate. There is no Board of Health in Baltimore City, and there's no equivalent. And in that same vein, when referencing a differing decision between the Baltimore City Health Department and the Baltimore City Health Commissioner, that can't actually happen because the Baltimore City Health Officer, they set the policy for and they head the Baltimore City Health Department. Second, the boards of health. So in the counties, really the boards of health, they operate as an extension of the state's executive power. And the county governing body, they serve as the de facto board of health. But when they do so, they put on their hat and they're actually an extension of the state authority. But they don't have the authority to function judicially or to legislate, as this bill suggests. County health officers, so they're considered state employees, but they're purely executive in nature. They don't pass laws or regulations. They don't sit as a judicial entity. They issue citations. They follow existing law. And the last point I want to make is just that the last clause here presents a significant legal conundrum, and that there could be some type of adversarial relationship between the health officers and the boards of health that can't legally exist because neither the health officer nor the boards of health have any judicial function to decide a final outcome of the case. And the health officer, by state law, they actually sit on the Board of Health as the executive officer and the secretary of the Board of Health, so they can't conflict with. So like I said, I'm happy to offer any assistance, and thank you. I urge an unfavorable report.
I know that there are questions, but I have a question for you. What is the current appeal process for a person that receives a violation?
Right, so this is going to depend drastically on several different things. So number one, were they enforcing a state law? Was it a county law? Was it a state executive order? Was it a local executive order? Was it something civil? Was it something criminal? So it's going to depend very differently. I can say, for example, I do some work with tobacco law and policy. So if a health officer in, let's say, Howard County is enforcing, or one of their staff is enforcing a law and selling tobacco to individuals under 21, they issue the citation. They usually use what's called the uniform civil citation. That's what most civil officers will use. And on there, there's like a little place where you can write the narrative. You write exactly what law it was, and then you check boxes at the bottom that relate to the appellate rights. Then that person, the retailer, has the option of paying a fine or going ahead and sending that into the district court. Many times these matters are heard before the district court when an actual citation issues. So it's going to differ, like I said, very drastically from topic to topic in all different parts of the local code and the state code.
Thank you. I have Delegate Shalega followed by Delegate Kaiser.
Thank
Delegate
you.
Shalega.
Thanks so much, Brooke. I don't know if you heard the testimony from Ms. Dewick, but there was no actual piece of paper citation issued. So are you saying that health officer had no authority to do that and Ms. Dewick could just ignore it all?
Sure. So I would also say, I didn't have time to mention this, but I really appreciate the conversation that I heard from all three of the business owners. I think it's really important that we hear from them about what's happening on the ground floor. So I just wanted to note that. So from reading between the lines, it sounded to me like she wasn't cited and there wasn't an order, and that there was someone from the county health department, I don't know what county it was, that came to her property and told her, like, this might be you might be violating this. Here's what you have to do. And I can't say whether or not, I don't know exactly what happened. And of course, assuming everything she said is accurate and true, this bill wouldn't correct that issue. But I can say it didn't sound like there was actually a citation or an order issued. They just said this is wrong. But nonetheless, this bill wouldn't correct that issue because the entities that are named in here that are charged with performing duties can't actually do those things in that capacity. So while
you're saying that our health officers are acting out illegally and improperly, because this is going on.
Sure,
whether you as a law student think it's legal or not, this is actually going on. And Jen is not the only one. I mean, I had like I said, a swimming pool owner that was cited by a health department that they just showed up and said, you're going to have to close your pool because blah, blah, blah. Nothing in writing, no citation, no order, no remedy, no place to go for due process. I mean, this is what is going on. So I'm glad to hear from you that you think it's a kangaroo court too. And maybe we should all just stop listening to the health officer. Thank you.
Well, what I'll say is that I've actually been practicing 10 years, so I'm not a law student, but I'm glad that I might appear that young. I always feel good about hearing that. So
you do. You look very young, Brooke.
That I'm not. So like I said, the whether or not, like what we're hearing from whatever's happening specifically in the field doesn't sound like there's a citation or order to issue pursuant to law. But if we have concerns about specifically, what's happening, there's confusion, the language in this bill just doesn't correct that. It doesn't do what we're talking about. What would be great, I suppose, if it did. And that's really the crux of what I'm trying to get to. It's not doing that. If a citation or order was issued in this case, and it didn't sound to me like that was the case, then there would have to be some form of due process. But I'm not hearing.
Thank you. That's exactly what we're saying. We're missing due process and we're missing a written complaint. So thank you.
So Brooke, just to clarify, is this the actual health officer or the inspector from the health department?
Oh, this as in with the health officer. I'm sorry, can you clarify?
For the person that gives a citation, is this the inspector's office?
Sure. So this will depend, I think, significantly again on what the source of law is. The health officer can enforce state law and they can enforce Board of Health regulations. Sometimes there are parts in the local county codes too, where they can enforce there sometimes. So it really just depends exactly on like what the law is and what the process is. There's so many different ways depending on what part of the code that there's an alleged violation. It's
but
very
the person that goes out, is it a health inspector that goes out?
Yeah, so generally I don't think it's the health officer that makes the trips. I think it's their staff. So a health, like an officer trained in civil enforcement.
Thank you. Delegate
Law
Kaiser.
enforcement too, I'm sorry.
Thank you. Delegate Kaiser.
Thank you, Madam Chair. I just had a question for Ms. Torton. I'm sorry if I'm pronouncing it wrong. What I heard you say was all the reasons why this bill is incorrect legally, but I don't know if, not all of our bills get drafted exactly as we wished, or we're not always aware of some of the downfalls. But what I think most people in the committee seem to think is that what happened to these individuals wasn't right and that there should be greater transparency. Do you have advice on how to better write this to ensure both the flexibility for the 24 jurisdictions as well as really what these people deserved, the transparency of knowing what the problem was?
Sure. So I can say that as it's written, it can't go forward this way. If the goal is to create, some kind of clear process or, a way to help folks understand what's happening, I would certainly be happy to look at this in detail and assist it. I think it would have to be a rewrite, whether that's an amendment rewrite or, some other way. I'm certainly happy to look into that and discuss. It's just, this doesn't do what we're talking about it doing.
Thank you.
Thank you. Any other questions? Seeing none, this concludes the bill hearing on House Bill 761. And Delegate Krebs, when you set up the meeting, can you also include Ms. Thornton, please? Thank you. Thank you so much for that. And thank you all for testifying on this bill. Next, we have House Bill 378, Delegate Kerr, Maryland Healthcare Commission Palliative Care Services Work Group. Delegate Kerr, good afternoon.
Good afternoon, Madam Chair and HGO colleagues. I am Delegate Ken Kerr, presenting House Bill 378 entitled Maryland Healthcare Commission Palliative Services Work Group. Palliative care is specialized medical care for people living with serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. The goal is to improve the quality of life for both the patient and their family. Palliative care is provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. Palliative care is based on the needs of the patient, not on the patient's prognosis. It's appropriate at any age and at any stage of serious illness, and it can be provided along with curative treatment. Palliative care is focused on the patient's quality of life. HB 378 is modeled after a similar study done in Hawaii in 2019 and requires the MHCC to form a work group to study palliative care services and make recommendations to improve and expand palliative care services in Maryland. I now ask that you call upon my panel, but first I want to thank them for hanging with us for these last 3 hours. They are Peggy Funk, Executive Director of the Hospice and Palliative Care Network of Maryland, Dr. Eric Bush, Hospice of the Chesapeake of Maryland, and Mike Brady, Hospice of the Chesapeake, who will present additional testimony and provide answers to any questions you may have. There is no opposition. If it please the chair, please begin with Peggy Funk.
Absolutely, Delegate Kerr. Ms. Peggy Funk, will you please get started?
Sure. Thank you. Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I really appreciate Delegate Kerr sponsoring this bill for us. We feel like it's an important bill, and I'd like to just share with you all the reasons why. So again, my name is Peggy Funk, and I'm the Executive Director of the Hospice and Palliative Care Network of Maryland. I appreciate the opportunity again to be here with you today to voice our members' support for House Bill 378. And as Delegate Kerr alluded to, this bill actually asked the Maryland Healthcare Commission to bring together stakeholders. And these stakeholders include patient advocacy groups, hospice and palliative care providers, healthcare facilities, and health insurers. So we want to ensure that we have all key stakeholders around the table. The legislation, as Delegate Kerr also said, is modeled after a similar bill that was done in Hawaii, and they concluded their study in 2019, which led to increased and much needed services for their state. We are confident that with this study, Maryland can as well begin to provide these services to offer supports to patients and their families with serious illnesses such as cancer, COPD, kidney disease, and as we've most recently experienced, the symptoms associated with COVID-19, among other serious diseases. The last piece of legislation on palliative care in Maryland, as you may recall or not, was enacted in 2015 with the passage of HB 581. This legislation pertained to hospitals only, and it was a great start for our state. It really was. Since that time, however, we recognize the benefits of having palliative care services available for patients and their families in their communities and in their homes. This study will shed light on what services are currently available, where we are falling short, and how to best deliver palliative care services. So research has demonstrated the benefits of palliative care. And the other thing to consider is that these benefits also align with the total cost of care in Maryland by reducing hospital admissions, saving dollars that can be allocated to other needs, and addressing disparities in healthcare. Our letter of support is included in your packet, and we respectfully request a favorable report for House Bill 378. Thank you.
Thank you for your testimony today and for your work. Next, we have Mr. Eric Bush.
Good afternoon. My thanks to Madam Chair, Vice Chair, and the committee for your time and consideration of this important legislation. Special thanks to Delegate Kerr for sponsoring. My name is Dr. Eric Bush. I'm a physician and Chief Medical Officer for Chesapeake Supportive Care. We're a community-based not-for-profit organization serving thousands of patients per year on hospice and palliative care in Anne Arundel, Prince George, and Charles County. I'm strongly in favor of House Bill 378. This legislation is instrumental for the further evolution of healthcare in Maryland and the ability of organizations to provide high-quality patient-centered care to those in the community with progressive chronic or catastrophic illness and help them remain at home. Lagging hospice utilization in Maryland is at least in part due to limited community-based palliative care. While palliative care has made progress in Maryland, challenges still persist, including education, cultural, both medical and community, coordination, communication, perception, a low home health care worker rate, high prevalence of multiple chronic conditions, high prevalence of housing problems, and limited trained providers. For each provider like me, there are 10,000 seriously ill patients needing assistance. This legislation would help address these barriers. Healthcare in our state continues to evolve. Implementation of structural changes such as total cost of care have been beneficial from a qualitative perspective for care delivery. In addition, prior palliative-focused Maryland legislation mandating hospitals provide inpatient palliative care have been steps in the right direction, but left a gap in providing palliative services to the community. Furthermore, the recent COVID pandemic has exacerbated disparities in care that require further attention. Despite these challenges, I've been blessed to be able to provide palliative care to multiple individuals that have benefited. My longest-running patient's been with me 10 years, even though she was diagnosed with leukemia in 1999. 8 years ago, I met a patient, Brian, 43-year-old Navy veteran at that time, diagnosed with stage 4 lung cancer. Given our collaborative work, he is still with us today, enjoying good quality as well as quantity of life. Community-based palliative care is fundamentally patient-centered at its core. It ensures patients have timely access to hospice care, and evidence demonstrates those patients receiving palliative care alone are 33% more likely to die at home, which is a preference of 70% of Americans. In addition, community care is a critical tool for Maryland's total cost of care, achieving triple aim of population health management, improving quality of care, and lowering per capita cost of care. Our organization proudly serves 900 patients per day in community for palliative care. However, we do so at a loss of $1 million per year, given the current status of palliative care in Maryland. Please support this bill so together we can determine how to best deliver this essential care at home for Marylanders that is sustainable and beneficial for all. I respectfully request favorable decision on House Bill 378. Thank you.
Thank you, Doctor, for your service to the state of Maryland. We had Ben Stephan, but he's actually not, I understand he's not here, but there's a letter of support in the file, and the bill does require them to put together this work group, and he's supporting it. Next, we have Mr. Michael Brady. Good afternoon.
Thank you, Madam Vice Chair, and thank you, Delegate Kerr, for bringing this forward. I'm really only here to answer any questions and to hear the dialogue that goes along with this, but I too am in full support with House Bill 378. Thank you for your time today.
Thank you for your work in Maryland. Are there any questions for Delegate Kerr or his panel? I see Delegate Krebs.
Thank you, Delegate Kerr, and thank you for this bill. I'm a huge supporter of palliative care, and this committee, before you were on it a few years ago, more than that, we did something on palliative care, and I don't remember what it was, to try to get some in every hospital. I don't remember if it was a pilot or not, but I'm just going to ask you if you're aware of that and make sure that we build off of that. But it was, we had a lot of discussion a number of years ago, and our committee was very much in favor of it. And I just hope that we figure out where we got with that. and then build on that and see why we sort of got a little bit, I think, stymied along the way. But I agree with all the testimony. I thank you, gentlemen, for the work that you do with palliative care. But that my question is just be aware of what we did in the past and try to find out where we left off.
Madam Chair, I'd ask Peggy Funk to respond, please.
We only allow once, but go ahead.
Okay. So thank you, Delegate Krebs, for the comment. And as I mentioned in my testimony, you're correct. And that was HB 581 back in 2015, I believe it was. And yes, that bill was wonderful because what it did is create a pilot program whereby it mandated that all hospitals with 50 beds or more have palliative care. It doesn't go quite far enough. We know how successful that can be, and we would like to see palliative care move out into the community and into people's homes, and we think that there's great opportunity there.
Thank you for reminding me of that. Thank you.
You're welcome.
And Delegate Kerr, that was my mistake. You never replied to her question. Anyway, are there any other questions for the great delegate and his bill? I don't see any. So I just want to thank you all for helping Delegate Kerr with his bill. And thank you for being with us today, okay? Have a wonderful day. That concludes the bill hearing on House Bill, my pleasure, on House Bill 378. And colleagues, we have two bills left. We're almost there. We have House Bill 370, Delegate Belcastro, certificates of birth, issuance of new certificates, sex designation, and then we'll have the last bill, 517. Delegate Belcastro, good afternoon.
Thank you, Chair Peña-Melnick.
My pleasure.
Chair Pendergrass, Vice Chair Peña-Melnick, members of the Health and Government Operations Committee, it is an honor to be before you today presenting House Bill 370, certificates of birth, issuance of new certificates, sex designation. Over the last decade, Maryland has shown its commitment to ensuring transgender Marylanders and their children have access to identity documents that accurately reflect their name and gender identity. House Bill 370 is a simple bill as it seeks to build on our prior success by providing procedural clarity and streamlining the arduous process of updating birth certificates through the Department of Vital Records. This bill would accomplish three things. One, it would create a standard procedure for transgender parents seeking to change their name and gender marker on their child's birth certificate. Two, would affirm that MDH may use a third gender marker of X for those that identify as non-binary. And three, streamline the process for updating one's gender marker on their own birth certificate. The idea for this bill came to me when a constituent, who you will hear from shortly, reached out concerned that her child was issued an amended birth certificate when it was updated to accurately reflect their father's name change. Currently, Vital Records must issue a new as opposed to an amended document when someone updates their name on their own birth certificate. But the department is not required to do the same when a person updates their name on their child's birth certificate. This realization, it sparked an interest in me to learn more about our process for updating birth certificates in Maryland. And through that research, I found that there is more we can do to bring this process in line with how we handle both name and gender marker changes on driver's licenses here in Maryland. Additionally, this bill would remove the requirement that an individual receive a court order or a signed document from a medical provider affirming one's gender identity. Instead, it would allow individuals to self-attest their gender identity under penalty of perjury when updating a birth certificate. Again, this would simply bring the Department of Vital Records in line with the MVA in how name and gender marker changes are handled on driver's licenses. Not having access to accurate forms of ID, such as birth certificates, can also be a barrier to an individual being able to access health benefits, establish parentage, or even travel. And for example, when an individual enrolls their child in school, in many cases, a birth certificate must be shown. If the information on one's birth certificate is not accurate, or if it's mismatched with other identity documents like a driver's license, then it leads to a situation where one has to out themselves simply to enroll their kid in school. Having accurate having accurate identification is an issue of both health and safety for many gender non-conforming, trans, and non-binary people who may be subject to discrimination when forced to carry inaccurate or mismatched documents. Due to many unnecessary barriers, navigating the world as a transgender person can be difficult. And by removing these barriers, we create opportunities for individuals to live better, more authentic lives. Thank you for the opportunity to present HB 370, and I respectfully ask for your favorable report.
Thank you so much, Delegate, for your testimony. Next, we have Ezra Town.
Hello. Hello, Delegate Pendergrass, Delegate Pena Melnick, and bill sponsor, Delegate Bill Castro. My name is Ezra Town, and my pronouns are they, them. I am here to ask for a favorable report without amendments on HB 370. Besides the fact that I am a transgender advocate and activist in Montgomery County, who is transmasculine and non-binary, I am also a parent of 2 children, which is why I am invested in this bill. Currently, my daughter, who is now 14, has a birth certificate with my given name on it. And my 9-year-old son, Leo, has one with my chosen legal name on it. I hadn't quite finished the process when Elsie was born. But so what this means for me is that, when I go to register Elsie for either a passport or to start in a new school, which requires identification like a birth certificate, I potentially out her as having a trans parent, which, is something she deals with anyway because of how infinitely Googleable I am. But it shouldn't be her burden to bear from the get-go. And when I tried to do so earlier, my lawyer told me that there was no clear way to make that happen, which is why I asked for a favorable report without amendments on HB 370. And thank you very much for allowing me to testify before you today.
Thank you for your testimony today. We appreciate it. Next, we have Lee Blinder.
Good afternoon, Chair Pendergrass, Vice Chair Pena Melnick, and esteemed committee members. My name is Lee Blinder. I use they, them pronouns, and I'm the Executive Director of Trans Maryland and also a very proud non-binary transgender Marylander myself. Trans Maryland is a multiracial, multi-gender community power building organization for Maryland's trans community. Trans Maryland runs the state's largest volume name and gender marker change program, and we offer peer-to-peer guidance and financial assistance to Marylanders who are seeking a name and gender marker change. Through that work, we've assisted countless trans community members who encounter barriers to name and/or gender marker changes with Maryland Department of Health's Vital Records Office. We're glad to collaborate with Vital Records through this crucial legislation to ensure that transgender Marylanders have timely access to new certificates of birth for either themselves or their child or children that accurately reflect their name after a legal name change and their gender if applicable. This bill will do 4 things. It will clarify that X is allowed on Maryland birth certificates, so people like me who have an X as our legal sex on our Maryland IDs can have a birth certificate that matches. Mismatching ID documents is very stressful for our community members. It allows gender to be self-select with Vital Records. Requiring provider attestation is a financial and logistical barrier that is not supported by leading professional organizations. The American Medical Association stated in 2018 that, to quote, the AMA opposes any efforts to deny an individual's right to determine their stated gender marker to determine their stated sex marker or gender identity. This would also be in line with how the federal government issues birth certificates. The State Department issues a consular record of birth abroad, and the State Department announced that gender is self-select through their entire agency, which includes consular records of birth abroad as of June 2021. It also ensures that birth certificates with name and/or gender marker updates are issued new and not marked as amended. As was mentioned earlier, there's a large variation in practice at the agency, and this will permit a streamlined and unified process for all people and ensures equity for transgender Marylanders who visit vital records for this purpose. And then, as I mentioned, it allows transgender people who are parents to ensure that their names are accurately reflected on their child's birth certificates. Passing this legislation is an easy way to equitize access to accurate identity documents for transgender people born in Maryland. And we would like to ask for your favorable report on HB 370. Thank you so much.
Our pleasure. Thank you for your testimony. Next, we have CP Hoffman.
Hello, thank you. Thank you, Chair, Vice Chair, members of the committee. My name is CP Hoffman. I am the Policy Director at Free State Justice, which is Maryland's statewide LGBTQ advocacy organization. One of the largest things that we do as an advocacy organization is run a legal services program for low-income LGBTQ Marylanders. So we assist individuals who struggle with this precise issue quite frequently. We've seen just great disparity in how the Division of Vital Records currently treats requests to change the birth certificates of trans children, of the children of trans parents. Sometimes they will issue a new birth certificate. Sometimes they'll say, oh, it has to be an amended birth certificate. And sometimes they'll say it's impossible. And it really just depends on who you get. And part of the problem is that there's not a specific, clear rule in the statutes. So this bill will help clarify that and create a standard procedure that everyone can use that will be the same for everyone and won't just depend on who you happen to get. I also wanted to talk about the self-attestation part of this, because I know that one of the things that often scares people when self-attestation comes up is, is this going to be something where someone can just willy-nilly, claim that their gender is, whatever? And the answer is no, because there's a provision in this statute that requires you to affirm your gender identity under penalty of perjury. So this is not going to be a situation where someone can say that, oh, actually, I'm a woman so that I can somehow use that on my birth certificate to go sexually abuse someone in a restroom or something. Because first off, your birth certificate has nothing to do with what restroom you can use. And also you'd be committing perjury as well as sexual assault. So I have many other things to say, but my time is up. So I encourage a favorable report on HB 370. Thank you.
Our pleasure. Next, we have Kathleen Connolly.
Sorry. Hi, I'm also a parent in Maryland, and I'm here. I submitted written testimony. It's the same written testimony from last year, so it's 3 pages of my detailed story. But basically, my daughter, who is now 18 and getting ready to leave home and go to college, has lived in Maryland her entire life and never been able to have an unmarked or unaltered birth certificate. Our whole story's in the written thing, but we started out as same-sex parents, my partner and I, when we had her, and we had these horrible exes. So she used to have an altered birth certificate. There was some advocacy and some law change to get rid of that. And now our birth certificates read parent and parent, which is great. However, when my partner came out as trans and changed his name, he only changed his middle name, not even his first name. He changed only his middle name. And we submitted everything to the Department of Vital Records, and they gave her an amended birth certificate. So my daughter's been, without an unaltered, clean birth certificate since birth. She's 18 years old, and it just seems kind of ridiculous that my husband has clean paperwork now. He has a state issued, his father was in the military, so he's a state issued birth certificate, and there are no alterations, no marks. My youngest son is adopted. He has a birth certificate that's unaltered, no marks, no amendment or anything like that.
I got married, I changed my name and my birth certificate's, I'm also adopted, but my birth certificate has no marks or amendments on it. But my daughter, for some reason, for 18 years has been, had this clean birth certificate withheld for, I don't really understand the reason, but, given the state of the world, I don't want her out there with anything that can be attacked by anybody who decided that they didn't want to accept amended birth certificates. And that's my time. Thank you.
Thank you so much. And thank you for sharing your personal story. We appreciate it and we're listening. We have next Michelle Schlefherder. And I'm so sorry if I did not pronounce your last name correctly.
It's quite all right. Thank you so much, Vice Chair, Chair, and members of the committee. My name is Michelle Schlehofer, and I'm here on behalf of PFLAG Salisbury, which is Salisbury, Maryland's chapter of PFLAG National. And we're asking today for the committee to make a favorable report of HB 0370. We just want to, again, agree with other people who are also expressing the need for a favorable report on the bill. Birth certificates are one of the most common documents that are used to verify a person's identity. And errors that are on people's birth certificates, particularly if they're trans, non-binary, or intersex, lead to a heightened scrutiny of documentation, and they create barriers to services for which these documents provide access. It's important to have accurate birth certificates because the process of having those certificates can facilitate people's access to medical and mental health care and other services and reduce people's stress of exposure to fear of being misgendered. So these types of changes improve the health, well-being, and safety of transgender, non-binary, and intersex people. It's also our position that having accurate documents are on the best interests of the state of Maryland, helping to ensure that state records are accurate, up to date, and reflect the people of Maryland. Therefore, it is our position that this bill would both support and protect transgender, intersex, and non-binary people, as well as be in the best interest of the state. And we're looking again for a favorable report through the committee. Thank you.
Thank you for sharing your testimony today. We really appreciate it. Are there any questions for Delegate Belcastro and her witnesses on House Bill 370? I have to look through the participant. I have Delegate Morgan, followed by Delegate Collison, followed by Delegate Shaleka.
Thank you, Madam Chair.
My pleasure.
Thank you, Delegate. I was reading through the fiscal note on this, and I'm looking, is there any age restrictions, and this is to the best person who can answer a question, is there any age restrictions on a parent changing a child's birth certificate for gender?
CP, would you like to take that question?
Yeah, I can take that. So that there is not an express age limit under existing law, but this bill does not change that at all. That was dealt with in a 2015 bill that this would amend to allow parents to change their children's certificates to have their own names accurately reflected.
Okay, so this is, well, I'm guessing from the testimony and reading the bill, it's just dealing with the parents changing their names, correct?
Well, so that provision of this.
Yeah, I got you. All right, thank you. Thank you, Madam Chair.
My pleasure. Next, we have Delegate Collison, followed by Delegate Shaleka, followed by Delegate Kaiser.
Thank you very much, Madam Chair. Thank you, Delegate Belcastro, and thanks to the panel for coming and speaking to us today, helping us to understand what is, rapidly changing in our world right now. So I just want to affirm, Delegate Belcastro, I think this is for you, but assign it to one of your panelists if you think that's important. First of all, really, really super important to have an accurate birth certificate. Not, that's absolutely true. And my understanding is that what you're attempting to do here is to align it with the processes that we use to change driver's licenses, which you can change your driver's license and there's no marker on your driver's license that says it's been changed. There's no amended, there's no anything like that. So this is simply aligning the birth certificate to that same process. In your in your work on this bill, have you heard of any issues that have related to the simplicity of changing the, making the changes on driver's license, which are much more prevalent document, carry around in my wallet, often have to show it for identification. Sometimes I even have to show it for my age now. Don't ask me why. And so yet it's, you know, it's something that's very easy to change. So I guess I'm asking, has there been any problems since we've made those changes?
So thank you very much for the question and allowing me to touch on that point. We have been doing this for years in Maryland when it comes to our driver's licenses, right? And also 10 other states and the federal government when it comes to issuing birth certificates has also done this. And in all of my discussions with Trans Maryland and Free State Justice who work on these issues day in and day out, no, we have not seen any widespread issues with this when it comes to Maryland, when it comes to the federal government practicing this on birth certificates as well. So thank you for the question and the opportunity to touch on that.
Thank you.
Delegate Shalega.
Thank you so much. So I've had a mom contact me, and there's another bill that my seatmate is putting in that her husband is a transgender who's gone through the change, and now she is a she. So if the children of this couple, and this is acrimonious in the divorce, and that's another story, not for this bill. So nonetheless, is there an age if the child would say, you know what, I want my birth certificate to stay the same? Is there some age where we're asking the children their opinion?
Thank you for the question, Delegate Shalega. And the answer to that is no. And unless you can shed any other light why that would be necessary in this bill or you know, across the board in the state, I would appreciate if we did not put that in this bill.
Yeah, I'm just thinking of this, my constituents' kids who would probably not want their birth certificate changed. And so I'd ask you to think about respecting the person whose birth certificate is being changed. If there is an age where they could have to give permission for that to happen. I think it's legitimate as you're asking to change someone's birth certificate and they may not be okay with that. So thank you.
CP, I see you wanting to get the bite at that apple. Go for it.
Yeah, so there is sort of an exception to what Delegate Belcastro said, which is the way that it's drafted. You can only amend your child's birth certificate when they're under 18. And when you're 18 or over, then you can amend your own birth certificate. So if the child is under 18, then it would be a situation where the parent would file with the Division of Vital Records to amend their child's birth certificate. If you were 18 or over, you would do it yourself. Presumably, if you were 18 and you really wanted it to say something else, you could do that.
So you could change it back. So for these children, if the parent changed the birth certificate against their will, then when they'd have to wait till they turned 18 and then apply to change it back. Is there a process for that, or do we need to put that in the bill?
They should just be able to use the same process. Also, I don't think that we're going to see situations where trans parents are insisting that their children change their birth certificates against their will and against the desire of their exes. That is I've never heard of someone doing that. This is really a bill designed to protect families that are maintaining a relationship with one another, and where the birth certificate is needed as an identity document on a regular basis.
Yes, I understand that, and I appreciate that. But we, as lawmakers, have to consider all the parties involved. So thank you.
Thank you.
I have Delegate Bagnall, followed by Delegate, 1 second, please. Hold on a second. By Delegate Krebs.
Thank you, Madam Chair, and thank you for bringing this bill forward. I appreciate that this is, you know, our parents are our parents, and this is affirming our parents. And there was a piece of testimony I read, the written testimony that said, you know, that a birth certificate should be a validation for children, not a tool to use to discriminate against them. So I just wanted to ask whoever was most qualified to speak to this about all the points of contact where that birth certificate would come into play, and whether this will relieve young people of a burden of sort of explaining that process over and over.
So I'd be happy to take that. There's lots of, we use our driver's licenses much more than we would our birth certificate, but we do have to utilize our birth certificates, right? When we try to establish parentage, when we try to get our children registered at school, when we travel, sometimes internationally, we also need accurate birth certificates as well. So we do have to use these documents in our daily lives, and there is no reason that anyone should have to explain themselves or justify themselves when they go to utilize those documents. So that is what we are trying to address, what we are trying to fix in this bill.
Thank you so much.
Thank you.
My pleasure. Delegate Krebs.
Thank you. And I need more information in general about the birth certificate, anybody's birth certificate. I always thought, and maybe I was wrong, that a birth certificate just showed who your parents were at the time you were born. Okay. And then let's say I get divorced from, let's say I'm heterosexual, I get divorced and I change my name 3 times. Does the mother go back and change the birth certificate because she's changed their name? Or is it, a driver's license to me is more of a living document. A birth certificate is at the point when you were born. Am I wrong about that? Just with anybody, not the trans community, but just with would someone go back and change their name because they got married 3 more times or what?
So I'll try and take the first stab at that one. So we currently in Maryland allow for name changes on your own birth certificate. Where the issue is that my constituent, Ms. Keneally, who testified earlier, where the issue lies is we allow you to change your name on your own birth certificate. But when Ms. Keneally's husband went to change their name on their child's birth certificate, the child was then issued an amended birth certificate. So this is simply a gap in the law, a gap in how we practice birth certificates here in Maryland. If we are already allowing a trans individual to change their name on their own birth certificate, why wouldn't we allow that and allow a new birth certificate to be issued when they go to change their own name on their child's birth certificate? And I hope that answers it.
No, it really didn't answer it. So just let's say it's me, myself, and I have kids, and then I get remarried 2 more times, and I want to change my name, but that's not, or what, but you had the father, when they're born, you had 2 people on the birth certificate, and at that point in time, they had a name, they had an identity. Why? Not like a driver's license that's going with you forever, but why isn't that something? I mean, can someone just change their name on their child's birth certificate if they're not transgender? Can I go in and just say, I want to change my name?
You could use the existing procedure, which is, again, inconsistent from person to person at the Division of Vital Records, to change your child's birth certificate. There's nothing under existing law that says that you have to be trans to do that. In fact, like, you can change your name on your own birth certificate for non-trans reasons. If you just change your name, because you want to, you are able to change your birth certificate to reflect that. And because we recognize that birth certificates are important identity documents that people have to use regularly when, starting jobs, when establishing benefits, when doing a lot of things. And so having a document that reflects who you are becomes crucial. Beyond, sort of it being a historical document. Yes, it is a historical document, but it's also a document that has ongoing effects as an identity document. And I know,
but if I can change my name currently, or if my kids are under the age of 18, if I could change my name on their document, why can't you? Why is it any different?
Yeah, so the issue is that the Division of Vital Records doesn't have a formal policy on it. And so they will, depending on who you get, sometimes they will do it, sometimes they will issue a new birth certificate, and sometimes they'll issue an amended birth certificate that X's out your name and then types the new name over it.
So right now, if I would change my name on my kid's birth certificate, it would be amended. Is that what you're saying? It would be called amended because the name changed?
Most likely, but again, it would depend on who you happen to get at the Division of Vital Records.
I need to understand just the basics first. Thank you.
Of course.
Delegate Kaiser.
Thank you, Madam Chair. And I'd like to follow on with Delegate Krebs's questions for CP Hoffman. I would first say I always have my daughter's birth certificate on my phone. And if anyone could read it closely enough, it does say father/parent's name for me. So getting things corrected would be nice. I was the first person on the planet to hold my daughter after she came out of my wife. So I am her parent. But to clarify what Delegate Krebs was trying to ask you, CP, if she were to choose to, if a heterosexual couple got a divorce, if a woman remarried, changed her name, married again, changed her name, and so forth, while certainly that information could be changed on any child's birth certificate, what we're ultimately trying to deal with is having a child's birth certificate accurately reflect their parents' gender now. And so the fact that someone heterosexual might get divorced multiple times, the child using that birth certificate isn't really dealing with any conflict necessarily. But what we're trying to do is make sure that, if I'm trying to understand it right, we're trying to make sure that the Division of Vital Records has a process for changing a child's birth certificate so they don't have to out themselves as trans or having trans parents in every situation. There is, by all means, when I travel to certain states, I say to Nancy, if you get in an accident and get pulled and get taken by an ambulance, I'm not going to claim to be your wife. I'm going to claim to be your sister, because I'm scared of saying I'm your wife in certain parts of this country. And I think it's that much harder to be trans in any place in the world than it is to be gay. And so I just think, from my understanding, you're just trying to make sure that there's an easy process, so kids don't have to deal with some challenges that sometimes come up.
That's absolutely right. And I will say that we have dealt with a lot of institutions that sort of operate under the assumption that women especially change their last name with like extreme frequency. And so if the last name on some document is different than something, than like, you know, what's in the file, they'll frequently be like, oh, well, you just got married or you got divorced or you know, something. Yeah. But if you change your first name, frequently it's an entirely different game. Like there are, you know, I know like Lee could talk to you about like the efforts that they've spent years on getting like names changed with the Maryland Medicaid system because like they just had no capacity to change someone's first name. They're like, well, we can change your last name, but we don't know how to change your first name. But it's, and so, you know, when you have a document with a different last name, it's often overlooked. But if it's a different first name, then that's when the questions come out. And where someone says, oh, wait, this says that, you know, their parent is, you know, Mark, not Brenda, just to pick two random names. So, you know, where's Mark? I need to talk to Mark because that's the person on the document. And then, you know, you might have to then spend an extended amount of time trying to explain the situation. You might have to produce other legal documents to demonstrate that you really are who the person on that is. And that can open up not just, you know, discrimination in that moment, but when we're talking about things like enrolling your children in school, then suddenly the school becomes aware that like, that's the kid with the trans parent. And they have the opportunity, you know, and that's going to be whispered about, you know, among, you know, all of the office staff, and the teachers are going to know, and like the kid's going to be treated differently than they would have been if like they just were able to enroll without that happening. Does that answer your question?
Yes, thank you so much. Appreciate it.
Thank you.
I have Delegate Saab.
Thank you, Madam Chairman. So a second ago, I thought I understood the bill, but now I'm a little confused again. And my question is, so are we talking about a parent changing the birth certificate of a child, regardless of what their age? So if I have a boy and when he's 3 years old, start looking like a girl to me, I'm not saying, I'm just using hypothetical. Can I go and change their birth certificate without proof that they have undergone surgery? Can you just maybe explain that to me?
So that's not the situation we're talking about here. What we're talking about here is individuals changing their names on their children's birth certificates. The process of changing, a individual's own birth certificate is different.
So we're talking about the proof of sex designation for the parent, not for the child.
Well, this bill will also change the way that what level of proof is required for changing your own birth certificate, or in the case of parents, your children's birth certificate. But it does not, say that you can just unilaterally be like, well, my kid looks like a girl, ergo, I'm going to change their birth certificate. Again, there's that, whole penalty of perjury. You can't just do it unilaterally. You would need to, have.
Right. Yeah. So the bill says, you're right. I mean, we wouldn't talk about that. So the bill says satisfactory proof. So what is a satisfactory proof if it's not given by a medical provider? What's the definition of satisfactory proof?
In this case, it would be an affidavit or a form issued by the Division of Vital Records that asks you to affirm under penalty of perjury that you or your child are that gender.
So give me an example, like how would I write it in a...
So currently the Division of Vital Records has a form that they use that you can send to them to request that your gender be changed on your birth certificate. It's a 2-page form. The first page is basically, saying, this is who I am. This is, what my birth certificate says my name is. And I affirm that, even though it says that I was female at birth, that I'm male. And then the second page is basically the same thing, but just filled out by your medical provider. And it says, like, I have treated this person and I affirm that, they're trans. This would basically be eliminating the need to do the second part of that. Now, I will say that in the vast majority of cases, what happens with the medical assessment is that someone goes to their doctor and says, I'm trans, can you fill out this form? And their doctor says, yes. And, after a short conversation, there are certain situations where it becomes burdensome because there are not providers who have experience with transgender individuals everywhere in the state. Certainly in Western Maryland and in the Eastern Shore, people often have to travel several hours to get to a trans-affirming provider. There's also a lot of issues with insurance networks where there might be one provider in your area, but they're not included in the insurance plan that you have or the Medicaid MCO that you're insured under. So
my question, I think this is going too deep and I don't want to keep this committee that much longer. So what about the minor child? If you're changing the sex of the minor child?
So it would be the same process as for adults.
They don't have a say in what sex they want to be. Is that what this bill does?
In reality, there is no history of anyone just suddenly deciding that their child is, really female, and when they, were assigned.
No, I understand that, but can it happen with this bill? Can it happen the way the bill is written? Can it happen? Yes or no? I mean, like I said,
can we allow the witness to answer, please? Go ahead.
I would say that there is a possibility that someone could request it, but that it would violate the affirmation under penalty of perjury. So it might be something that could be issued, but it would be illegal and that person could be prosecuted.
Thank you. Thank you, Madam Chairman.
My pleasure, Delegate. Are there any other questions for this panel? Let me just make sure. Yes, Delegate Hill.
Thank you. CP, there was a lot of going around. So, and I for the people in the balcony seats, okay, just to get this all clear. Initially, there was an analogy made between children of heterosexual couples who have name changes, but that really is not a fair analogy because typically a parent who undergoes a name change doesn't bother changing their child's birth certificate, right? So this is a particular situation that in many ways is unique to the trans community, as I understand it. And if that's correct, can you just clarify that we're not talking that parents routinely go around changing their child's birth certificate because the parent is going through something? And I think you hit on a little bit in response to Delegate Kaiser's question, but if you could just separate those two for us so we can be really clear.
Yeah, so
we don't straight equivalency.
So we don't have a history of parents, for the most part, just willy-nilly changing their children's birth certificates. That is not something that is broadly done. There are times where someone will seek to change their child's birth certificate, to change their name on their child's birth certificate when they're not trans for, reasons of safety or something else. So, domestic abuse survivors might want to take advantage of this provision also. Now, in those situations, they're more likely to, get a specific court order also telling the Division of Vital Records to issue a new birth certificate. But that's sort of an added burden that we don't think you should have to go through. It's not something that happens more broadly, and there's not a history of, people just willy-nilly just trying to change, facts on their children's birth certificates. The one exception is sometimes people will try to get their ex marked off of the birth certificate in the middle of a custody dispute, but that's sort of a different situation, and there's different laws that govern there. This really is, sort of a situation that it is not unique to the trans community, but it is much more common among us. And, I've not talked about my own personal experience here today because it's a little bit, my child was born in New York City rather than in Maryland. So, their situation is different and it's governed by New York law. But their birth certificate does not have my name as it is now on it. And if I want to demonstrate that I am their parent, I have to also have, other documentation with me. And, if we're traveling internationally and I need to have, a lot of stuff with me so that I don't run into trouble, at immigration somewhere where someone is suddenly like, are you trying to traffic this child who looks exactly like me? Let alone, parents where, their child might not be biologically related to them, or interracial families where people might be suspicious that parent is really related to them. And so just having these documents really does just make everything so much easier for us on a day-to-day basis.
Thank you very much.
Thank you.
And I was thinking, I don't see any other questions. I always like the members to go first because sometimes they ask all of them. I don't need to, but I was thinking also, as you are, today, and you have, for example, your will, right? I'm thinking, shouldn't it reflect your name as it is today, and would your child have a hard time proving later on because the name is so different? That is an interesting question. And that's the lawyer in me thinking about that as well. Any other questions? I don't see any. Thank you for being so patient to the committee and allowing these discussions. Really, I appreciate it. And I want to thank you all for coming here to the committee. As you see, we listen, we respect you, and we appreciate your testimony today. We do have come now to the last bill of the day, and that is Delegate Robin Lewis. And Delegate Robin Lewis, it is House Bill 517. Actually, that concludes the bill hearing on House Bill 370. And now we're on to House Bill 517, and that is Delegate Robin Lewis, Consumer Health Access Program for Mental Health Addiction Care Establishment. Good afternoon, Delegate.
Good afternoon, and thank you so much, Madam Chair.
My pleasure.
Esteemed colleagues, I come before you to present House Bill 517, entitled Consumer Health Access Program for Mental Health and Addiction Care. This is a consumer rights bill. This is a piece of legislation that will make it easier for people in Maryland seeking behavioral health services, whether it's mental health treatment, substance use treatment, etc., to get the care they're seeking. We've done an amazing job in the state of Maryland. So many of you sitting on this committee are responsible for breaking barriers to insurance coverage for the people of our state. We passed just a few years ago the Easy Enrollment Act that allows Marylanders to check a box on their tax returns to get easier access to health insurance coverage. We've done so much to expand access to Medicare and expanded the services that are covered under that public health insurance program. But we still face challenges, even though we've cut the uninsured rate in half in our state, thanks to the Affordable Care Act or Obamacare and all the changes we've made. There's still obstacles that people face when they're trying to get mental and behavioral health and substance use treatment services. How do we fix that? How do we close the gap? How do we break those barriers? This bill proposes to create a statewide consumer assistance program that we're calling the Consumer Health Access Program. It will stand up inside the University of Maryland School of Social Work CARES program, an ombuds sort of structure that Marylanders can contact when they're covered, when their insurance coverage doesn't allow them to either get mental health services, or their claims are denied, or there's any other sort of confusion that makes it impossible for them to get the care they need. As you all know, thanks to the public health crisis that we're in, so many more people are in need of mental, behavioral, and substance use services in the state of Maryland. Every year for the past few years, opioid overdose deaths have increased. We've seen an increase in suicides. And this is affecting Marylanders in all age groups, of all backgrounds and races and nationalities. So here's another opportunity to break those obstacles, close the gap, get people covered. So the bill will establish a 3-year pilot program, again, housed at the University of Maryland Social Work Addiction Treatment Center. It will stand up a hub and spoke model of service or consumer assistance service delivery. A toll-free helpline, outreach and education, partnerships and collaboration with service providers and nonprofits and state and local agencies, and reporting requirements. All of that will be included in this 3-year pilot. This model is based on effective and successful programs rolled out in New York, Connecticut, and Vermont. The bill does have a fiscal note. We're asking for, a little money, but I don't know about you. I think the people of Maryland are worth it. With that, I'll close and ask for your favorable report. I'd like to turn the mic over to my panel of supportive witnesses who'll go more deeply into the details. With that, I thank you.
Is there someone that you would like to follow you?
There's so many amazing people. I think I will start. What is the order? I don't have the
I have
order.
Deborah Steinberg next.
Yes, ma'am. If Deborah Steinberg would present. Thank you, Madam Chair.
My pleasure. Thank you for your testimony. Deborah Steinberg.
Thank you. My name is Deborah Steinberg with the Legal Action Center on behalf of the Maryland Parity Coalition. Thank you for the opportunity to testify in support of HB 517. We thank Delegate Lewis for sponsoring the Consumer Health Access Program bill, which will help Marylanders with mental health and substance use disorders enroll in insurance, understand and navigate their benefit coverage, and get legal assistance when their coverage is denied. In this time of unprecedented need for mental health and substance use treatment, the Consumer Health Access Program, or CHAP, would be a one-stop shop to help all Marylanders get the care they need and assist providers who often serve as their patient's advocate. Many Marylanders never access behavioral health treatment because the insurance system is too complex, and individuals and families need substantial hands-on help in the midst of a crisis. As someone with a mental health condition who has been in that crisis and who has lost friends to suicide and overdose, I can promise you that this is necessary. CHAP would be composed of a central non-governmental hub and 8 nonprofit organizations across Maryland, so that it has both a centralized helpline and on-the-ground presence in communities for outreach, education, and assistance. CHAP would be staffed by individuals with lived experience to reduce stigma and would have an equity focus to ensure culturally and linguistically appropriate services. CHAP will work with the various state agencies and non-governmental organizations that offer assistance on some of the activities that CHAP would provide, though none of them provides assistance in a single entity for all insurance-related problems regardless of payer. The full scope of consumer needs, from enrollment to understanding insurance coverage, to finding a network provider, to filing a complaint, and helping providers so that they can focus on their job, treating patients. No agency is authorized to provide direct representation, and none are evaluating where consumers consistently face problems accessing care and proposing solutions to create system-wide reform. It's at these junctures where one agency's authority begins and ends that Marylanders fall through the cracks and lose access to life-saving care. There is a cost to establishing CHAP, but it pales in comparison to the cost of not treating our friends and family. Several other states have similar proposals. They have submitted testimony. They save consumers, they have similar programs. They save consumers and the state money and ensure better access to care. I worked in a similar role in Massachusetts before coming to Maryland and would be happy to answer questions about logistics and efficacy. We urge you to issue a favorable report on HB 517 so that Marylanders have access to the same assistance. Thank you for your consideration.
Thank you for your time and for your work in Maryland. We appreciate it. Next, we have Ms. Laura Mitchell.
Hi, thank you. I am Laura Mitchell. I am a Montgomery County resident, transplanted from Wycomico County. And I have for 30 plus years been navigating the tumultuous pathways to mental health and substance use disorder treatment for my son first, and then for my granddaughter. She was hospitalized in November and discharged December 3rd, and we are still seeking care for her as post-hospitalization. We've not been able to find any care, PHP, IOP, psychologist, psychiatrists to treat her. Very complex situation. And it's very, very stressful. I've spent 20 plus hours a week trying to make those hundreds of phone calls, dozens and dozens of emails, trying to get care for her, preferably in network. But because if I go out of network, my deductible doubles and my coverage halves. So that's not affordable. And I just can't do that. So every minute that I spend seeking that care for her is time I don't have time. I don't have to care for her and provide the support she needs as she continues to backslide and become suicidal again, and we end up back in the hospital. So the costs are increasing constantly. Rather than treating the problem, we're addressing the symptom repeatedly. This entity, if it were in place right now, I have no doubt that I would already have care for her. They help you navigate not just finding insurance if you need it, but finding care with someone who takes your insurance. If that is not possible, then within the time and distance metrics, then they help you connect with someone who is out of network and get all the process done that has to be done properly, or you end up paying. The other thing that this does is collect the data of those recurring problems that many of us face that have me doing the same thing now that I did 30 years ago with my son and have not been solved yet. Because all that data will be collected in one place. They can share that information with MIA, with legislators and regulators, and make sure that we fix the problems. I need this bill to save my granddaughter. Thousands of others need help to save their children. Thank you.
Thank you, Ms. Mitchell, for sharing your story about your granddaughter. We appreciate it, and I hope and pray that there's a solution soon. Next, we have Kim Wireman.
Hi, everyone. I'm Kim Wireman, testifying for Maryland Addictions Directors Council in strong support of HB 517. MATSI is an association of providers delivering SUD and dual recovery treatment across the state of Maryland. We're at the front lines of the opiate epidemic, and we see every day the need for a one-stop shop like CHAPS, not only to help consumers, to help family members, to help outreach workers and everyone involved. We know that time is of the essence when someone is willing to go to SUD treatment, that services need to be delivered immediately. There are a few facts that bring out the strong need for a program like CHAPS. First, SAMHSA's 2020 Key Indicators for Substance Abuse and Mental Health reports that 41 million Americans had needed SUD treatment, but only 2.5 million actually received treatment. 37.5 million didn't believe they needed treatment. But of those who were committed to getting treatment, the major reason for not being able to obtain treatment was lack of healthcare coverage or the cost of care. In Maryland, we have 2,900 people, just under 2,900 people who overdosed, the seventh highest rate in the nation at the time. In Baltimore City, where I lead an addictions treatment agency, ever since calendar year 18, we've had 1,000 people a year die from overdose, mainly fentanyl overdose. When we look at those numbers and that compelling need, MATSI asks not why do we need this program, but why haven't we gotten this program? Thank you so much.
Thank you for your work. I know it's very difficult work. We also have Shannon Pankin, but I do not see the name at all. Susanna, did she log in?
No.
Okay, thank you. Next we have actually Mr. Actually, there's a favor with amendment. Why don't we take questions from this panel, and then there's only one witness, Mr. Neil Karkanis. So are there any questions for Delegate Lewis and her panel? 1 second. And I don't see any. Actually, I do. I see Delegate Hill.
Oh, you knew that was coming. Thank you, Madam Chair. Delegate Lewis, thank you for this bill. So just real quick, we've been fighting, I don't know, for at least the last 7 years to try and make sure people understand that we have parity between somatic health and behavioral health on all levels. So what and I don't know whether this is you're throwing in the towel and saying we don't have it and we're not going to get there. But I'm wondering why this approach, as opposed to maybe training navigators who are already there to, have special understanding of what the behavioral health networks are, or working through other channels that exist to make sure that people can access to the insurance coverage and information they need. So that's the question.
And thank you so much, Delegate Hill. That's a great question. We in Maryland are fortunate to have a number of state and local agencies working diligently to break obstacles between Marylanders seeking care and caregivers. There are agencies, for example, in the Attorney General's office, the HEAU team, There are organizations, nonprofits like that Healthcare Access Maryland, HCAM, that has trained navigators on call, ready to help people connect to insurance coverage and solve other problems. The difference with this bill is that it will stand up a structure that will focus like a laser specifically on obstacles to behavioral health services, behavioral health insurance coverage, and add another layer of a robustness of energy and attention to folks specifically struggling with, the lack of network adequacy and out of network struggles for behavioral health. So it's certainly true that we'll be building on the assets we have, but the reality is there's more we need to do. I think the model we're proposing under this bill, learning from states that have done the same thing effectively, New York, Connecticut, where we have a lot in common in terms of our health delivery and health insurance structures, is a benefit and worth piloting for the 3-year period we're proposing. I hope I answered your question. Thank you.
Any other questions for the delegate or her panel? Seeing none, we're going to go now to our last witness of the day, favorable with amendment, Mr. Neil Karkanis.
Good evening, Madam Chair.
Good evening.
And members of the House Health and Government Operations Committee. My name is Neil Karkanis on behalf of the League of Life and Health Insurers, here to testify favorable with amendments on House Bill 517. I'll say from the, on the front end, there's certainly a need here, and that's undeniable. And I'm happy to work with the sponsor to work through some of these issues. But though the intentions of the bill are commendable, we have to agree with many of the points made by the Maryland Insurance Administration in their letter of information, which I believe should be in your bill file. So I'll just outline briefly 3 big points. One is there are some provisions of the bill that imply that the program would assume the regulator's role or would simply be duplicative to the regulator in certain respects. So that's both with the Maryland Insurance Administration and the Health Education Advocacy Unit. 2, there is another provision that would require the Maryland Insurance Administration to potentially produce confidential information to a party, despite their good intentions, is frankly just not a regulator. So we'd want to address that issue. 3rd point, there is a provision that could be read that the program is offering legal services or legal assistance. It's unclear what the scope of that representation is, if those individuals are agreeing to that representation, and the several legal issues associated. So generally, we are supportive broadly of the intent here, but we do think the bill does need some work. I'd be happy to work with sponsor Lewis on these issues. Thank you for your time.
Thank you for your testimony and for being willing to work with a sponsor. Are there any questions for this witness? All right, seeing none, thank you so much for your testimony today. And members, this concludes the bill hearing on House Bill 517, and it also concludes the work of the day. I hope you have a blessed evening. Thank you for your attention. We appreciate it. Take care.